session. That's a symposium session, a cooperation between two countries, ASH and ISHBT. And I and Dr. Somanath thank the organizers for this opportunity. The first talk is by Dr. Mark Walters. Mark Walters, MD, is the Jordan Family Director of Blood and Bone Marrow Transplantation Program and Interim Director of Research at UCSF, Benioff Children's Hospital, Auckland, and also the Professor of Pediatrics at the University of California, San Francisco. He is also the Program Director of the California Institute of Regenerative Medicine Alpha Stem Cell Clinic at University of California, San Francisco. He is active in cooperative clinical transplantation trials and has led several NIH-supported investigations of hematopoietic cell transplantation for sickle cell anemia and thalassemia. His research is focused on hematopoietic stem cell transplantation and novel cellular therapies for hemoglobin disorders, genomic editing, and gene addition therapies as curative treatment strategies in hemoglobinopathies. We invite proudly Dr. Walters to give the ASH ISHBT plenary talk.
Thanks very much for that kind introduction, and it's really a pleasure to be here in Kerala and Kochi to deliver this talk. I especially am grateful to Alexis Thompson, who's president of ASH, and to Olok Srivastava from Vellore, the Christian Medical College, who I think both of whom are instrumental in my making this important journey. And of course, to initiate and extend the collaborations with my colleagues in India that I have had the opportunity to nurture over the last several years. So today I thought I would just focus solely on the gene addition trials in beta thalassemia major and severe sickle cell disease using the lentiglobin vector. So this is how the treatment works. It begins with mobilization, either by plerixafor and GCSF in the thalassemia recipients or with plerixafor alone in the sickle cell disease recipients. The stem cells are harvested and then shipped to a central manufacturing facility where the transduction with the lentiviral vector occurs. Those are cryopreserved if they meet release criteria, are then shipped back to the transplant center where a single dose of busulfan, single agent busulfan, is administered, followed by thawing and infusing of the gene therapy modified cells. These are 2-year studies with the option of a 15-year period of follow-up in a long-term study. So this is the basis for all of the clinical data that I'll show this morning. So the first study that we conducted was called North Star, or HGB-204, studied this lentiglobin gene therapy in transfusion-dependent thalassemia. It was an international study, ultimately enrolled 18 patients, all of whom have completed the 2-year study with a median follow-up of 32 months. The initial results were published earlier this year in the New England Journal. So this shows some important characteristics. We divided the patients into those who have a beta-0 genotype, and this is important because they make no endogenous hemoglobin at baseline. That accounted for 10 of the 18 patients. The remainder had a non-beta-0 genotype, such as beta-E, beta-0, that's so familiar in this country. They make endogenous hemoglobin, but as they aged, they transitioned to transfusion dependence. As it turns out, the transfusion requirements were not different between these two groups, and all of them had some degree of liver iron loading with a smattering of splenectomies, perhaps related to that. The study delivered myeloablative doses of busulfan with the AUC shown here. The vector copy number on average was 0.7, so fewer than 1 copy of the vector per CD34 positive cell transfused, and the drug product cell dose is shown. The time to neutrophil engraftment and platelet engraftment is shown, median of 18.5 and 39.5 days, and everyone had neutrophil recovery. The incidence of platelet engraftment was 78% by day 60, 94% by day 100. Thrombocytopenia, though, was a problem in 4 of the patients highlighted by the red curves in the figure on the left. These patients had a platelet count that was still less than 100,000 1 year post-infusion. When we looked at characteristics of the 4 patients shown in the table on the right, we noted that splenomegaly was not present, so probably didn't play a significant role, but none of these cases of prolonged thrombocytopenia was associated with severe bleeding episodes. A mild case of nosebleed and a mild case of rectal hemorrhage in patient 1111. So something to consider, probably related to the manipulation of the cells ex vivo as well as the cell dose delivered. The most common complication after the treatment with single-agent busulfan is what one might predict after a single-agent autologous stem cell transplantation, that is mucositis and febrile neutropenia, which was experienced by most of the patients. Other episodes of bleeding were noted, and then an important complication, veno-occlusive disease of the liver, occurred in approximately 10% of the patients. And this was accounted for the most significant adverse event with thrombosis. But there were no grade 3 or higher drug product related adverse events, no episodes of graft failure, no vector-mediated replication-competent lentivirus was detected, and importantly, no sign of clonal dominance in the 2 years of follow-up that we have to look at. Excuse me, so this gives a bit more information about the veno-occlusive disease of the liver that happened. Both patients had significant liver iron. In one case, there was a transaminitis at baseline. The busulfan pharmacokinetics are shown myeloablative, but within the target range we use, which is 3,600 to 5,000, both treated by defibrotide with eventual full recovery. But this is an important consideration, particularly in the thalassemia recipients who have liver iron loading before the transplants, particularly if it's associated with any sort of liver inflammation. So this shows the most important endpoint, so this is an important slide to remember. This shows the impact of the lentiglobin gene therapy procedure, the treatment, on whether or not transfusion independence was achieved. So there's a light blue and a dark blue section of the line graphs here, and the dark blue indicates the time since the last red blood cell transfusion was delivered, ranging from 19.4 to over 40 months. The current hemoglobin is shown. So it ranges from 9 to 13.5. So these are the patients who had this non-beta 0 genotype for whom some endogenous hemoglobin is produced at the baseline. And transfusion independence occurred in 8 of 10 of these patients in the initial trial. The patients with a beta 0 genotype, so a more severe form of thalassemia, in that there's no baseline endogenous hemoglobin produced, 3 of the 8 achieved transfusion independence, and in 2 cases, this transition from light blue to dark blue, not needing transfusions any longer, didn't occur in 2 cases until 18 months post-infusion. And then the last hemoglobin is shown here. So the level of hemoglobin in the blood expressed over time is quite stable. The beta 0 genotype patients are shown in red, and you can see it varies between 8 and 12 grams per deciliter. So it makes sense that if you need 10 grams of hemoglobin to be considered transfusion independent, why some amount of endogenous hemoglobin was necessary in a subset of the patients. The patients who had the beta 0 genotype who did not transition to transfusion independence still had a significant reduction in the number of transfusions administered, so a 50% reduction, which is clinically significant, I think. And in the non-beta 0 genotypes, a different kind of response, 82 and 27% reduction. So the important relationship was that, first of all, that the vector copy number in the drug product really represented the number of transduction events in hematopoietic stem cells. So it very nicely predicted the vector copy number that was present in the blood months after the infusion. So not much fall off there. And the other important relationship that's shown on the right is that the hemoglobin AT87Q, that's the marked hemoglobin, the gene therapy hemoglobin, how much is produced in terms of grams per deciliter is related to the vector copy number in the blood cells at 6 months. So you see this nice curve. The red dots are from the patients enrolled in the French study, but at about a vector copy number of 1, you see this inflection to produce around 8 grams per deciliter. So vector copy number of 1 is really the target moving forward. And if that can be achieved in everybody, you would predict that would have a more consistent benefit. So based on those 2 observations, we've gone on to launch these 2 additional trials. In this case, the beta-0, beta-0, and the non-beta-0, beta-0 genotype patients are treated in 2 separate studies, 207 and 212. So first, the results in the 207 patients, 11 treated so far. So these are patients with a non-beta-0, beta-0 genotype, and 4 of the 7 have beta-E, beta-0 thalassemia as a genotype. Again, very similar to what we saw before. Young adult patients, although the age now has been decreased to 12 in this case, still have some degree of liver iron loading, no cardiac iron loading, and about a quarter have had splenectomy. The busulfan area on the curve is the same. It's myeloablative busulfan with very good cell dose. Time to neutrophil and platelet engraftment is similar with the duration of hospitalization shown. There are now 8.5 months follow-up. So what happened in the interim? Why the new study? Well, there have been new improvements in the way the transductions are occurring so that the vector copy number now, using the new manufacturing techniques, is approaching 2.5 to 3, as opposed to 0.5 to 1 that was seen in the initial 204 study. And that's reflected nicely in these 2 figures, which shows the vector copy number in the drug product on the left, the input, and then the proportion of CD34 positive cells that are transduced at that vector copy number, again in the input. And comparing the current study, the vector copy number has a median 3.4 with the range shown here, as opposed to 0.7 in the initial 204 study. And then that translates into having, instead of 25 to 30% of the cells transduced, closer to 80 to 90% of the cells transduced. So just based on these data alone, based on that relationship that I just showed you between the vector copy number in the blood and the hemoglobin A T87Q in the blood, we should do much better on this trial. So the toxicity profile is shown here. It's very similar to the 204 study with mucositis and febrile neutropenia occurring in most of the patients. Still a problem with veno-occlusive disease of the liver shown here, but no graft failure, no patients have died in the 204 or this study, no vector-mediated replication competent lentivirus detected to date, and no evidence of clonal dominance. So here are the results, extending now through 12 months post-infusion, and this shows the vector copy number in the blood. And in most cases, the range looks very good in the 1 to 4 vector copy number of the blood, which should indicate that 90% of those cells are expressing the T87Q hemoglobin. But there are still some problems, probably having to do with the quality of the hematopoietic stem progenitor cells that are harvested and then transduced. Very much lower vector copy numbers shown here, suggesting that we're not really transducing a true stem cell population in some of the cases. And then that's reflected nicely in the hemoglobin A T87Q level. And by 9 months, the levels are approaching 8 to 10 grams per deciliter, again, a level that should be sufficient for transfusion independence. But this is not universal. In these 2 patients, the increment in the T87Q level is much lower, reflecting the lower vector copy number that was achieved. So pink is good. That's the T87 gene therapy hemoglobin. And the range is shown here from, oh, on my screen it's pink. Sorry, it's red on the screen. I'm not colorblind. So 3.6 to 10.2 is the range. The hemoglobin E is in green, and hemoglobin F is in orange. So, and some of the patients still have some residual hemoglobin A that's produced at baseline. So in almost every case here, transfusion independence established with good hemoglobin levels by 6 months post-infusion. So what a great result, right? But it wasn't universal. Again, 7 of the 8 patients with more than 6 months follow-up did achieve transfusion independence, which means 1 did not, even with this improved vector copy number transduction efficient manufacturing method instituted. And in this case, this is a patient of mine from Oakland. We were as bold enough to introduce phlebotomy to treat her iron overload by 6 months post-infusion. So she's both becoming, entering negative iron balance and transfusion independent. So quite a nice result in that particular case. So in summary, the 2-year phase 1/2 North Star study of lentoglobin gene therapy study for transfusion-dependent thalassemia is completed. 8 of 10 of the non-beta 0 genotype patients are transfusion independent, with a smaller number with the beta 0 genotype. The lentoglobin manufacturing process has improved. We're now incrementally seeing vector copy numbers in the 2.5 to 3 range, as opposed to 0.7, with a correspondingly very good level of percentage of transduced cells. I will show the results of the next phase, the phase 3 North Star 2 study, with 7 of the 8 patients with 6 months follow-up having achieved transfusion independence. Safety profile has been very similar in both, with a problem of veno-occlusive disease of the liver that must be taken into account. And the 212 study, which is the study in the beta 0 patients, is ongoing. And I wanted to acknowledge the participants in this study and the sites where the patients were cared for. So let's transition now to sickle cell disease. One important thing about the T87Q lentiviral gene therapy hemoglobin that's used is that the T87Q has anti-sickling activity. So this study focused on adults with significant sickle cell disease, and the primary objective was safety, but we also had secondary endpoints having to do both with the hematology after gene addition therapy, as well as the clinical response to the treatment, and those data are being collected now. So it's the same procedure as far as the transduction. The difference here is that because GCSF cannot be given safely in sickle cell disease because the leukocytosis will elicit a significant vaso-occlusive event, we initiated the study with a bone marrow harvest to collect the CD34 positive cells, but because of difficulties that I'll show you in a minute, we quickly transitioned to plerixafor mobilization that, as it turns out, can be done safely in the sickle cell disease recipients. Otherwise, the procedures of the study is the same as in the transfusion-dependent thalassemia patients. So this is complicated, but it basically shows our transition from bone marrow in blue to mobilized peripheral blood cells in C. And in the middle, it was this transition period where we were still using the bone marrow, but had instituted this higher vector copy number lentoglobin transduction manufacturing procedure. So these are higher vector copy numbers, but still bone marrow here. So I'll remind you, purple is bone marrow with better vector copy number, blue is plain vanilla bone marrow, and red is the new improved peripheral mobilization with improved transduction. So here's the breakdown in terms of number of patients treated. 9 with bone marrow alone, 2 with this bone marrow plus better manufacturing, and then in the current era, 11 with mobilized stem cells and optimized, refined manufacturing. So here are the results of the patients. The age does not vary. The gender breakdown is shown. Most had vaso-occlusive events as the reason for being enrolled in the trial, but a few had strokes or acute chest syndrome as the indication for transplantation. And all of the stroke patients were receiving regular transfusions to prevent secondary stroke. And there was one case where the TR jet, the tricuspid regurgitant jet velocity, exceeded 2.5 meters per second. That's a risk factor for early mortality in adults with sickle cell disease, approached 40% at 3 years. So that was the reason for enrolling that patient. So just a couple of things I want to point out in this slide about the treatment characteristics. In Group A, the bone marrow group required a median of 2, but in one case, 4 bone marrow harvests to get enough stem cells to do the transduction. So that's not very much fun if you do any bone marrow harvesting. And as opposed to 1 to 2 mobilizations with peripheral blood collection with using plerixafor as a single agent. So this nice improvement. The busulfan levels were, as we discussed, between this case, 4,500 and 5,000 was the target in the sickle cell disease study. The period of follow-up, short with mobilized cells, but getting out to 2 years. for the bone marrow. And the time to engraftment, and I'll just say that using the mobilized stem cells does confer a more rapid time to both platelet and neutrophil recovery after the treatment. That's important. So comparing the bone marrow harvesting and the plerixafor, there were adverse events in both, mostly related to pain, as you might imagine, but actually more pain, particularly procedural pain, associated with the bone marrow harvesting, so that the adverse event profile, I would argue, is the same, if not improved, when we use plerixafor mobilized stem cells in lieu of a bone marrow harvest to get the cells for the transduction. The safety profile after the drug product was infused is shown here, and again, not surprisingly, most of the patients developed mucositis or febrile neutropenia. A few had painful events that is disconcerting, probably preventable, so that needs to be looked at again. And then you may notice that there's something important missing. No veno-occlusive disease of the liver. So patients with sickle cell disease, this has been my observation, allogeneic transplantation too, really don't get VOD that often. So these are the most important complications. No cases of VOD, as I said, no vector-derived replication-competent lentivirus detected, and a highly polyclonal repopulation noted in this study, but also in the thalassemia study. So no clonal expansion related to genotoxicity observed in any of the lentiglobin recipients to date. So, busy slide, listen to me, don't look at it. So we're going from bone marrow in light blue to mobilized plerixafor stem cells in red, and also transitioning from old to new manufacturing methodology to raise the vector copy number. So what we're seeing is a nice improvement in the vector copy number, approaching about 2.5 to 3.5 in the current era, which corresponds to more of the vector, more of the stem cells being transduced with vector, going from 20% to 80%, and then the CD34 dose improving with using mobilized stem cells in lieu of marrow, now at about 7 CD34 positive cells, 7 million per kilo recipient. So this translates into a higher vector copy number in the blood. So red again is the mobilized blood using the optimized manufacturing, now seeing 2.5 to 3 vector copy number in the blood, as opposed to very low levels of vector copy number using bone marrow in the old manufacturing methodology. And this expresses as better hemoglobin in the blood, the last patient now at 8.8 grams per deciliter at just 3 months post-infusion, whereas in the first group, bone marrow with the old manufacturing utilization, T87Q hemoglobin A less than 2 grams per deciliter, not very likely to have a clinical effect, very likely to have a strong clinical impact. And this just shows the vector copy number in the blood settling out to very much what it was in the drug product. So this is the takeaway slide. This shows the incremental improvement in the good red hemoglobin A T87Q. So in the first iteration with bone marrow in the old manufacturing methodology, very low levels of red. And now in each case we're seeing with a combination of fetal plus the T87Q approaching the same level of hemoglobin S in green in the blood, and in some cases nicely exceeding that level. So we're on the right track. We're now achieving that goal of having at least 50% of the hemoglobin in circulation being the T87Q anti-sickling hemoglobin to counteract the effect of the hemoglobin S, which should render these patients much more like sickle cell trait than the severe sickle cell disease that they had coming into the trial. And another way of looking at it is at the 3-month and 6-month visit. And so you see this nice increment going from group A, bone marrow, to group C, mobilized peripheral blood stem cells with the improved manufacturing, with a total hemoglobin of 10.8 at 3 months, and now astoundingly 14.2 hemoglobin median in the last group C patients enrolled in the trial. This is as of May 2018. So in summary, hopefully I've showed you the evolution of the hemoglobin 206 protocol. This is the gene therapy study for sickle cell disease that has improved with drug product characteristics that are improving in patients in this group C. That's the group that had mobilized stem cells with optimized manufacturing. Now making 3 to 6 grams of the hemoglobin A-T87Q at 3 months, and one patient making 8.8 grams, which is 62% of the hemoglobin A-T87Q at 6 months. The study levels of the vector And the hemoglobin A maintained through 2 years is encouraging, means that this is stably engrafted and stably contributing to erythropoiesis in these patients. And the safety profile is consistent with myeloablative conditioning. So we're continuing the study, focusing now on the prolixafor mobilization and apheresis, and we'll have additional data and longer follow-up to establish whether there's really a clinical benefit that follows the hematological changes that are important. And here are the important collaborators in this HGB-206 study led by Julie Cantor at the Medical University of South Carolina and John Tisdale, where's John? There he is, at the National Institutes of Health in the hematology branch in Bethesda. Thanks very much.
Thank you, Dr. Walters, for that revolutionary treatment in hemoglobinopathies. 1 or 2 questions. We have got another 2 minutes, 3 minutes.
So how do we bring this to India? That's really why I'm here. I think we need to think creatively about these look fantastic, and because we're modifying one's own stem cells, it should be broadly applicable. But how do we bring it to where the patients live? That's really what I'm focused on, I think, in the future.
Excellent talk. I just have one question about the vector. This is a lentiviral vector, right? So it's getting integrated at some part. Is it a targeted integration, and why do you have more safety if you have multiple integrations, because it will possibly go to multiple locations?
Yeah, it's self-inactivating, so it's not targeted integration. And the chicken HS4 boundary element, those were removed to improve the titer. So it goes in, but it can't come out, and that's why the replication-competent lentiviral assays have been negative. But it integrates wherever it happens to go. And in some cases, we're seeing up to 10,000 unique integration sites. So the issue of genotoxicity in the long term is an important one that needs follow-up.
Is happening at the same place for all patients, or is it totally random?
Totally random. Yeah, there's no conserved unique integration sites that have been observed in any of the patients, either with thalassemia or sickle cell disease enrolled to date. Well, what we do is we have this, I don't know if this is appropriate, but if a single clone integration site represents more than 30% of the integration site analysis, then that would prompt cessation of enrollment and a look at what was happening in that particular. So 30% seems really high to me, but I have seen single clones represent as many as 10% of the clones in any particular snapshot in time. So clonal expansion will happen. Whether it's related to the integration site or not is really too early to tell.
Thank you, Dr. Walters, for this wonderful talk, and we hope and we pray that you will take it to a higher heights and finally bring it to India. Somadat.
Ladies and gentlemen, it's a great privilege to welcome our next eminent speaker on this symposium, Professor Dr. Mary Blakely. Dr. Blakely is a pediatric oncologist and hematopoietic stem cell transplantation physician at Fred Hutchinson Research Center in Seattle. Her research involves the development of new immunotherapies and transplantation strategies to improve the outcome of patients with high-risk leukemias. Her laboratory is currently focused on 3 projects, namely strategies for engineering hematopoietic stem cell transplant grafts to reduce graft versus host disease and augment the graft versus leukemia effect. Also, immunotherapy targeting minor histocompatibility antigens to T-cell receptor gene-modified T-cells for treatment of post-HCT relapse, and the T-cell immunotherapy targeting recurrent fusion proteins, indels, and other mutations in leukemias. Dr. Blakely is also the Director of Cellular Therapy and Transplantation for Pediatric Leukemias at FHCRC and the coordinator of the Integrated High-Risk Leukemia Clinic at Seattle Children's Hospitals. Ma'am, it's our tremendous pleasure to invite you to give your talk on this plenary session. Thank you, ma'am.
Good morning. Thank you very much for the kind introduction. Thank you very much to ISHBT and to ASH for giving me the opportunity to speak with you this morning. So the focus of my talk today is on chimeric antigen receptor T cells for treatment of hematological malignancies. And this is a very exciting field. What I'm going to talk about is I'll provide some background for those of you who are less familiar with chimeric antigen receptor or CAR T-cell therapy. Then I'll focus on some of the recent clinical results of CD19 CAR T-cell therapy for acute lymphoblastic leukemia. We'll discuss the limitations and challenges of this approach. I'll move on to what's going to happen next, and if time permits, then we'll discuss CAR T-cell therapy for other hematologic malignancies. So by way of introduction, chimeric antigen receptor is a hybrid receptor that's introduced onto T cells by usually genetic methodology. It is comprised of several components, very essentially an antigen binding domain, which links through a number of different molecules to natural T-cell receptor signaling apparatus, most commonly the CD3 zeta chain. So looking in detail, we have the binding domain, and most of the current CD19 specific CARs use the single chain variable component of FMC63 monoclonal antibody, with a couple of exceptions. At the moment, these are murine, but more recently in the clinic, there are trials that are evaluating humanized and fully human FCFEs in order to reduce the potential for immunogenicity and improve the persistence of the CAR T cells. The next components of the hinge and spacer and transmembrane domains. These vary quite a bit between different CAR constructs. The most typically in the clinics, there are one combination of a CD28 or a CD8 alpha or IgG4 constructed together. And we're gradually learning that the details of this are quite important, in particular that the spacer length matters and has to be optimized particularly for the SCFE and for the particular antigen that's being targeted. So there's a lot of optimization work required. Very important are the co-stimulatory domains. So you will have learned already that there are different generations of CAR T cells. In the first generation, there is no co-stimulatory domain. In the second generations, there are CD28, 41BB, and some other options. So the second generation include one or the other. A lot of research is going into this at the moment, and what has been learned is those CARs that use a CD28 signal rapidly and with a very strong signal strength, but the T cells that result tend to be effector T cells and persist less well than the 41BB. The metabolism is different, it's largely glycolytic. For the 41BB, they signal less intensely, more slowly, but have better persistence and more likely to result in T cells with a central memory phenotype. Recently, there's been some clinical evaluation of third generation CAR T cells, and these typically include two co-stimulatory domains. And the Baylor group have recently shown that third generation, which include a 41BB and a 28, function better than a CD28. The cartoon actually shows an atypical situation with the CD28 zeta first, but usually this combined construct ends in the CD3 zeta signaling domain. And the whole package is usually delivered by a viral vector, either a gamma retrovirus or a lentivirus, although some groups are also investigating other alternatives for introducing the chimeric antigen receptors, such as transposons, which has some safety and financial advantages. So to create a CAR T-cell product, the most important thing to note at the moment is this needs to be done on an individual patient basis. So that means that T-cells have to be acquired either from the patient in an autologous setting or from a donor, whether it's a HLA-matched donor as in the transplant donor, or a third-party unrelated donor. Peripheral blood, or most commonly an apheresis product, is obtained. The cells are taken to a GMP lab. They're activated, transduced with the viral vector containing the chimeric antigen receptor. The cells are enriched and expanded in order to reach the cell dose that's desired for the patient. And then the patient is typically receives some lymphodepleting chemotherapy, and that's to reduce the chance of rejection and also to create a cytokine milieu that favors the expansion of the T cells. And the T cells are infused. And the current protocols, the whole production takes between 2 and 4 weeks, some as little as 10 days at the moment. So we won't go into the history in a great deal of detail, but I want to point out that there's been really 3 phases in the development of CAR T cells. So in the late 80s and into the 90s was really the first conceptualization and proof of concept of CAR T cells with Zili Geshar, Israeli scientist. And at the same time as that was happening, was the very early days of T-cell immunotherapy with expansion of tumor-infiltrating lymphocytes led by Steve Rosenberg at NCI, and the start of adoptive antigen-specific adoptive T-cell immunotherapy, first by Phil Greenberg and Stan Riddell at the Hutch. Meanwhile, Michelle Sadelain at Sloan Kettering was starting to engineer murine T-cells and genetically modify them, which really paved the way to the first generation CARs. Then in the 2000s, we saw the second generation CARs, both the 28 and the 41BB, and CD19 was validated as a target. And this era sort of culminated in the submission of the first IND application to the FDA to run a clinical trial to evaluate CAR T cells in humans. Since 2010 has been really exciting times with the first clinical reports of efficacy of second generation and more recently third generation CAR T cells with CLL, acute lymphoblastic leukemia and non-Hodgkin's leukemia initially. And the results have been so exciting that this field is absolutely booming in the States and internationally. And in the recent year, we've seen the first FDA approvals for T-cell gene-modified products for pediatric ALL last August, and then the first products for non-Hodgkin's lymphoma at the end of last year, and a second approval in this spring. A fourth one is rumoured to be on its way. So before we get into too much detail, I wanted to just summarize where I see the state of the field of CAR T cells. I would say that we have seen absolutely dramatic complete responses in very advanced relapsed and multiply relapsed and refractory patients with heme malignancies, justifying the designation as a breakthrough therapy. That is true with CRs in more than 80% of ALL, approximately half of non-Hodgkin's lymphoma, and a significant minority of CLL. We do see some patients that seem to have very durable responses and potentially cures of up to 6 years after just receiving the CAR T-cell therapy, having been previously highly refractory. But unfortunately, what we're seeing more and more is that the long-term durability is compromised in the majority of patients, and long-term disease-free survival after CD19 CAR T-cell therapy only actually occurs in the minority of patients, which really means that there's a lot of work still to be done in the field to optimize this therapy and make it curative for most people. We've learnt that efficacy is related to the persistence and expansion of the CAR T cells, and has some relationship to the burden of the disease at the time after infusion. This is a little bit more variable between trials, but in general, patients with very high tumor loads tend to have less durability of their responses, and that's true in studies in ALL and in non-Hodgkin's. We're seeing that the failures are related to two factors. One is lack of persistence of the CD19 CAR T cells, and the more common is actually to antigen escape, so the leukemic cells finding some way around to evade the product under the immune pressure. So we're seeing the majority of relapses after CD19 CAR T-cell therapy leukemia that no longer expresses a CD19 molecule that can be recognized by the SCFE. So now I'm going to focus a little on pediatric ALL. So this is the data that informed the first FDA approval of tisagenlecleucel, and the data was published in the New England Journal in February of this year. The CAR T-cell product was created, and this multi-center international trial was informed by earlier phase 1-2 studies performed in Pennsylvania, University of Pennsylvania and Children's Hospital of Philadelphia. And those earlier studies showed a 93% complete response for these heavily pretreated children. The chimeric antigen receptor is a second generation FMC63 construct with a 4-1BB co-stimulatory domain in a lentiviral vector. And the phase 2 pivotal trial involved 25 centers in 11 countries worldwide, with manufacturing in the States and also in Germany. A dose of 3 million CAR T cells per kilogram were delivered to the children after, in most cases, receiving lymphodepleting chemotherapy. Of the 92 patients enrolled, 75 actually received the infusion. In a number of cases, the production of the CAR T cells was not successful, and in another number of cases, the children progressed and or developed severe adverse events which precluded the infusion of the cells. The clinical data is overall extremely encouraging. The primary endpoint was a remission by 3 months, either a complete remission or a complete remission with incomplete hematological recovery, and this was achieved in 81% of the 75 patients infused, and so that's a little lower if you account for those that didn't get the product. But by 12 months, 50% of the patients remained in remission. The cells did persist beyond the 9 weeks that we now recognize to be sort of critical for the persistence, and the response is correlated with the persistence of the cells and with B-cell aplasia. So as you know, CD19 is expressed on normal B cells, and we use B-cell aplasia as a quick evaluation of the functional persistence of the cells. So if the normal B cells are still wiped out, then the leukemia should also be controlled. Of the relapses reported, 15 of the 16 were CD19 negative. Very important to note was the toxicity rate in this trial was high, with an intensive care admission rate of 47%, mostly for the cytokine release syndrome, which required vasopressors in 25% of the kids. There's also a significant number of children that developed neurological complications, what's now called the cytokine-related encephalopathy syndrome. I'm now showing you some data from our own institution, which has been evaluating a very similar CAR in children as well as adults. This is also a FMC63 41BB lentiviral type CAR. And you can see from the data here that the clinical results are very similar in a trial of 45 children, with complete remission achieved in 93% of those infused and 89% of the total group. The 1-year event-free survival was also very similar at 50%, so it's very comparable product to that evaluated in the Eliana trial. I'm showing you this data because it illustrates the problems that we're facing. So Rebecca Gardner, who's the first author on these studies, shared with me that the follow-up, which shows a continuing drop, continuing relapses beyond the 12 months. And this is sort of representative of what the broader experience in the country is being. So over the very long term, 20-25% perhaps are staying in remission. Our data also illustrates what we're observing with the addition of allogeneic transplantation after CD19 CAR T cell therapy. It was intended that we would try to avoid allotransplant and all of its toxicities, but our policy was for children that had not previously received an allotransplant that remained the standard of care. So if they were achieved a remission with the CAR T cells, they would go on to allotransplant. And most of the families accepted that recommendation. If patients had not previously, for those that had already had an allotransplant, we were much more neutral about the recommendation, and most of those patients didn't. And what we're seeing is patients that did receive allotransplant had much better outcomes and much more durable remissions, reflecting the need for consolidation therapy at this time. This was particularly true in patients that had short B-cell aplasia, so short functional persistence of the CARs. Turning now to what's going on in CD19 CAR T cells in adult ALL. This is a long-term follow-up study published by the group at Memorial Sloan Kettering in February of this year. And the data illustrates what we've been observing about the lack of durability of many of the responses. And so they are also seeing a less than 20% long-term event-free survival. What they've noted is that patients that are able to achieve an MRD negative complete remission have a better chance of staying in long-term remission after the CAR T cells, but patients that don't get MRD negative with the CAR T cells inevitably do relapse. Most of their patients did achieve MRD negativity, and that was related to the peak of the expansion of the CAR T cells. They looked at a number of variables, and essentially what they observed is that high disease burden was a negative prognostic factor, but the number of previous therapies and the history of having a transplant or not previously did not have an impact. And this group observed something different with the transplant, and in fact in this study there was no difference between patients that were transplanted and not transplanted. You'll note though that the outcomes of the transplant amongst the 17 patients was relatively poor, with more than 30% relapse and more than 30% non-relapse mortality. In adults with ALL at our institution, we've been seeing generally similar results, with 85% of the patients achieving MRD negative CRs with CD19 CAR T cells. And it's also the same finding that achieving a MRD negative complete response is extremely important. Again, at our institution, the proliferation of the T cells correlates with clinical response. But we're seeing much better results with allotransplant as consolidation. And so generally for patients that have received CD19 CAR T cell therapy, it's recommended to go on and have consolidation allotransplant afterwards. So I think what I've emphasized is that while the clinical outcomes are extremely exciting, there's a lot of work to be done, and we have to understand the determinants of the success and failure of CAR T cell therapy in order to continue to move forward. So some of the things that are important are the ability to manufacture a product, the ability of the cells to expand and persist, and the relapses. Relapses are related to either lack of persistence or antigen escape. And more recently, we've seen examples where leukemic cells have actually been transduced with the CD19 specific CARs and are able to escape by that mechanism. For the persistence, the minimum requirement is 9 weeks. The factors that feed into that is they can't be rejected, so we've learnt that conditioning is very important before giving the CAR T cells. Remember that these are murine-derived antibody fragments, and that conditioning with cyclophosphamide and fludarabine is better than cyclophosphamide alone. We generally don't see benefits from second infusions, at least with the murine CAR T cells, or that may change with the humanized versions. The expansion depends somewhat on the burden of disease. So patients that have very little disease, the cells tend to expand less well, and we can do some adaptive dosing, taking that into consideration. The product properties are incredibly important. I mentioned the co-stimulatory domains. The T cells that are being delivered are also important. So an earlier T cell population, naive central memory or stem cell memory, are more likely to persist in the long term, and this has to be taken into consideration of the manufacturing. So giving a lot of effector cells that are less likely to be successful. And in CLL studies, the immunophenotype of the product has shown to be predictive. The persistence and expansion is also associated with cytokine release syndrome. So just like in allotransplant, one hopes for a small amount of GVHD for patients with heme malignancies. In CAR T cell therapy, we hope for a little bit of a signal of fever and flu-like symptoms, certainly not the intensive care admissions. The tocilizumab, the anti-IL-6 receptor antibody that is given preemptively for management of the cytokine release syndrome and corticosteroids for the encephalopathy, do not appear to affect the success of the treatment. So the move is to give those earlier. I mentioned the difference in the 28 and the 41BB products. And although these two types of chimeric antigen receptors have very similar signaling, as I mentioned, the signaling is more rapid and more intense with the 28s, which then goes on to drive a glycolytic metabolism and an effector memory phenotype in comparison to the 41BBs, which are activated and expand more slowly but persist better. The CD19 escape is important. So there are 3 mechanisms of escape. So the first is relatively uncommon, but is happening consistently, and that is we're seeing lineage switches of leukemia from ALL to AML phenotype. This seems to be particularly common in MLL, KMT2A rearranged leukemia in the babies. And also in older patients with mixed phenotype acute leukemias. The most common escape is the alteration of the CD19 molecule. We've recognized that the FMC63 antibody recognizes an area in exon 4, and this recent publication in Nature Medicine demonstrates mutations and including frame shifts, indels and deletions in exon 4 as correlating with the CD19 escape, so that the CAR T cell can't bind leukemia with this altered CD19. And then this very recent report of a transduction of leukemic T cells so that the leukemia expresses CD19 and the CD19 CAR, and the CAR then can't eliminate the leukemia. It seems to be rare, but is certainly very concerning and is pushing the field to consider the concept of third-party chimeric antigen receptor T cells where the TCR and all the HLA molecules are knocked out so that you can have a sort of universal donor, avoid transducing your leukemic cells, and also that could contain some of the costs. So there's a great deal of interest in developing more CAR T cells, and a lot of conferences and a lot of research groups interested. And how things are going to move forward are in more consistent manufacturing, using defined products and working towards the off-the-shelf approaches that I mentioned. Working on the persistence of the CAR T cells, on optimizing the conditioning and making sure it includes fludarabine. The humanized CARs, which are less likely to be rejected. Vaccinating the patients to improve persistence. So there are trials going on where people are giving T antigen presenting cells in order to further expand, boost the cells within the patient after the leukemia has cleared. The CAR designs are still being optimized. As I'll show you, people are working on additional targets and moving towards bispecific CAR T cell products, so that not just one antigen is being targeted, but multiple to reduce that chance for escape. The expense and feasibility is obviously a major limiting factor of getting this to all the patients in need, and the field is pushing for off-the-shelf approaches with knockout of the TCRs and HLA. A universal CARs that recognize a peptide tag in monoclonal antibodies, so you can give the peptide tag antibodies and then give the CAR T cells to recognize them would be one approach to address this. And then the viral vectors come with both safety issues and associated with all of that cost, so transposon-delivered CAR T cells would be an advantage there. This is a CD22 CAR first clinical report, so getting away from being totally dependent on CD19, and this is the first proof of principle that there are other successful targets, and it also is sort of the first step towards bispecific CARs. So Terry Fry and his colleagues published the study earlier this year. It involves 4-1BB lentiviral CAR targeting CD22. It's a phase 1 trial with 21 adult and children with very advanced acute leukemia, most of whom had already received and ultimately failed CD19 CAR T cell therapy. The CD22 CARs did persist for a period of time, which is not as good as the CD19 CARs in general, but generally reasonably sufficient to induce remission in a number of the patients, in 73%, and a durable remission in about a quarter, which is not too dissimilar from the CD19 CARs. The CD22 loss of expression was the major limitation in the durability of the remissions, and this is post-translational at the protein level. So first, proof of principle that CD19 is not a uniquely effective target of CAR T cells for heme malignancies. I'm going to skip over the section of CAR T cells for other hematological malignancies, and I'm happy to take questions later on about non-Hodgkin's and multiple myeloma and AML. And I'd like to finish up by concluding that CAR T cells can induce very deep remissions in patients with very advanced relapsed and refractory heme malignancies. Sometimes they're durable, often not. There's serious toxicity. They're currently extremely expensive because they're made for individual patients. But the future direction includes CAR T cells targeting multiple antigens to prevent escape, and the development of off-the-shelf approaches to mitigate the cost limitations. Thank you very much for your attention. Thank you again to the organisers and to all my colleagues that contributed to this field and the funding, etc., that allows it all to happen.
Thank you so much, ma'am, for your revolutionary talks on this immunotherapy in pediatric ALL. And can I have one or two questions from the audience? Yes, sir, please.
Excellent overview of the CAR T. Just a quick question. Do you have any idea like what would be the best predictive biomarker to stratify the patients for the CD19 positive CAR T besides low disease burden?
Low disease burden seems to be important and somewhat related to that. My colleagues have found that high LDH is a risk for poor outcomes, both in terms of toxicity and failure of the products. What's not a risk is how many times the patient has been treated before, the chemotherapy refractoriness, or the having had a transplant previously.
And what would be the good biomarker to identify whether this product which we are generating from the patients would turn up into the good CAR-T versus bad CAR-T?
So detailed characterization of the products is going on by all the groups that are investigating, and there hasn't been one common theme that's coming out of it, only a high content of T cells with a long lifespan ahead of them, so the central memory and the naive T cells rather than affected T cells. And that can be controlled by selection of the T cells, but that's a little borderline for feasibility in terms of cost because each cell selection is expensive. So there are a number of groups sort of working on a way to apply brakes to the differentiation of the cells during the manufacturing, and that may be more feasible and ultimately very useful to keep the cells relatively young.
Lovely talk, Mary, as usual. I have a very practical question, and that's probably related to the practice at your unit. It was nice to see the long-term, survival of these patients who had received CAR, and as you mentioned, maybe 20-25% will have persistence of disease remission. Now, what's the practice at your unit? You're delivering a CAR, so are you offering a transplant option to all of these patients when you enroll them as a consolidation therapy? And if yes, what are those group of patients where you plan HSCT as a consolidation in addition to CAR after getting the remission?
Yeah, so our general practice for children that are in good health that have not had a previous allotransplant is that after the CD19 CAR T-cell therapy, if they can get into a deep MRD negative remission, then we recommend transplantation for all the children. That's based on this population. It's the standard of care, regardless of how you get them into a remission. If they're relapse refractory patients, they do need a transplant. That perspective is not shared across all the different institutions, and Philadelphia is the sort of notable exception, although there's diverse opinions within CHOP as well. So yes, we recommend a transplant for those patients that haven't had one before, and most families are happy to accept that recommendation. We do take into consideration that the patient has had the CD19 CAR T cells and that they're able to induce very deep remissions. So for particularly very young children, babies, if they are MRD negative, and particularly if we have next generation sequencing, we can see that their disease is very well controlled, we're much likely to offer a transplant that is less intense and less toxic to avoid the late effects if they've had the CD19 CAR T cells first. For a child that's already had one transplant, then we mostly
sorry
don't.
to interrupt, ma'am. We are running short of time. Thank you.
We can talk later.
Okay, yeah.
Thank you.
Thank you. Thank you so much, ma'am, for your excellent talk. Now, it's also my pleasure to invite our Indian's perspective by Dr. Rahul Parwar. He's an assistant professor and the head of the Immunoengineering Lab at the Department of Bioengineering and Biosciences, Indian Institute of Technology, Mumbai. His main area of research is T-cell engineering for cancer immunotherapy with major focus on developing the effective and affordable CAR T-cells technology. In addition, his group is also involved in exploring the roles of T-cells in skin inflammation and autoimmune disorders. He has been awarded with several awards, one of which is the Melissa K. Bambino Memorial Award by the Skin Cancer Foundation, USA. He's also an ad hoc reviewer in several journals like the Journal of Immunology, Pediatric Dermatology, Journal of Investigative Dermatology, International Archives of Allergy and Immunology, Dermatology, Proteomics, and Oncotargets. Sir, we request you to give your talk on this Indian scenario. Welcome to you, sir.
morning, everybody. Good morning, everyone. First of all, thank you so much to the organizers for inviting me here and giving this opportunity to present some of our work. And so it was indeed pleasure hearing Mary about all the CAR-T overview, so I don't need to give a lot of overview of the introduction of the CAR-T, which I also had in my few of my slides, so I can skip them. So I will mainly focus on the Indian perspective of the CAR. And one thing is sure, that after Mary's wonderful talk, you may be thinking that we should also have the CAR-T in India, right? Or in India, this technology should be there so we can also treat our patients in India because we have too many, right? In fact, more than anywhere on this planet, we would have, I think, highest number of patients. But unfortunately, our patients don't get these kind of state-of-the-art treatment. And I think you see everyday patients, and they are basically in need of these kind of technologies, but they don't have it. And there are obvious reasons to it, why they don't have it. So that's what I'm going to focus on this CAR-T technology and challenges of this technology in Indian perspective, and why we need the indigenous CAR-T cell development, and where we are and what we are looking for. Okay. So as a previous speaker mentioned, that CAR-T is basically a combination of cell therapy and gene therapy, where you take out the immune cells from the patients, and and in the laboratory or on the industry, you isolate these immune cells and genetically modify them using some gene delivery vehicle. In majority of cases, it's lentiviral vector, retroviruses, or transposons. And once you have these genetically modified cells, you expand them in enough dose for the clinic and reinfuse them with lymphoablative conditioning so that they are accepted very well and they proliferate and can eliminate the cancer for the long term. I think this you already have seen a similar thing, the anatomy of the CAR, where you have the two major domains. One is outside the cell and another inside the cell. So outside the cell, what you have is the antibody-derived antigen binding domain, which recognizing the tumor cell. And once this domain recognize the tumor cell, the endodomain provides the signal to the T cell to kill the cancer cell. And then there are many advantages of CAR T cells over the TCR-dependent recognition, where in CAR T cells, you do not need the HLA typing, right? And then you can also design CAR T cell virtually for any target antigen, whether it's protein, carbohydrates, so it's very versatile as well. And then we also heard that what are these different generations of CAR, right? From first generation, where there was no co-stimulatory domain. Second generation have one co-stimulatory domain, where majority of the clinical trials you have seen, they use second generation CAR. And the third generation CAR, which is up and coming, where the two co-stimulatory domains are the CD28 and 41BB. So if you see here in the summary of the many clinical trials, especially the CD19 positive CAR-T, what you see that majority of these trials are happening either in the United States or Europe, and some started in China. India is not there. And majority of these treated diseases are CD19 positive malignancies, there are some few else, but majority of them are ALL, like hematological malignancies, right? So, and if you summarize the data of these clinical trials, there are many, but I have here only focused on three major centers. CHOP, who is working with Novartis, NCI, and Memorial Sloan, and these all are CD19 positive different malignancies, and what you see here is very good response rate. So highly effective, and this data also you have seen in the previous talk that coming from the Memorial Sloan, where the low disease burden has better survival, especially long-term up to 60 months, almost 5 years. And similar data coming from CHOP, again published very recently in early 2018. Both papers came almost at the same time. And here you see the 41BB CAR, this is also 22 months. There is a lot of discussion which one is better, CD28 or 4-1BB. 4-1BB is suggested to be highly efficacious because it persists longer compared to CD28. But data here from the NCI, from Memorial Sloan, they use CD28 CAR. But still, I think if you have low disease burden, this CAR seems like working, at least efficacious. So we don't know exactly in the clinical settings what is a long-term benefit of CD28 versus C41BB. So based on phase 1 and 2 studies, the first CAR-T approved, and now it is, Novartis is having the license to commercialize it. And another, now many approvals are coming, in fact, monthly or 6-monthly basis, where so Kite in another one, and for multiple indications are added almost on a monthly basis on this CAR-T. So what is Indian perspective now? So if you see, in the United States, I think 600 patients, that's what Carl June was telling me last month, 600 pediatric patients who need its CAR-T. In India, we have several, actually hundreds, because in India, I was reading some of the Dr. Memchandy's, the reviews, and here I found 25,000 children they diagnosed every year. And incidence is almost very similar to United States or Western countries, but unfortunately, our relapse rate is much higher than anybody else. Again, I think I don't need to tell you because you know these things better than I do. So that means we have so many patients, and majority of our patients, they choose palliative care and don't survive because we don't have these kind of state-of-the-art technologies. Another challenge, so we have the need, there is an opportunity, but the challenge is that cost. It costs $500,000 per patient, and you all know that majority of us, including our patients, can't even afford it because it's too high. But not only the cost, but another important criteria here is we don't have even good infrastructure as well as technical skills to do it. One thing is certainly cost is very high, but we also don't know how to do it, right? So we need both the things. We have to reduce the cost, and we have to develop the infrastructure as well as know how to do it. So to perform this, we got really lucky that we got the collaboration with Tata Hospital. So IIT Bombay, Tata Hospital, and Terry Fry was very generous that he was happy to mentor us in clinical manufacturing as well as for clinical training on the CAR-T. So he's like our subject matter expertise where we can do scientific exchange, we can go there, and he also visited my lab almost 2 times in last 3 years. So what we did, so we started like we will do bench to bedside from in India, and then for preclinical manufacturing, so this part may be boring to many of you because this is more laboratory type of work, there's no clinical data involved, but just bear with me for some time. So here, so any technology when you want to develop, you want preclinical, translational, and clinical, right? So here, if you do the preclinical work for the CAR T-cell technology development, you need 3 major things. You need to have the CAR construct, then you have to synthesize it and clone it, and then you have to put this construct in the gene delivery vehicle. So those could be lentiviruses, retrovirus, transposon, or the CRISPR, whatever those technique of the modifications you want to use. And then finally, you genetically modify these T cells using these gene delivery vehicle. And in our lab, we use the lentiviruses. So now here you have, we also have a FMC63 clone for the SCFV, and then we humanized it. I will not go through this all humanization process because it's a complex process, but more on the bioinformatics side. So after this entire platform, we have generated 2 products, tested, actually we generated 4 of them. 3 of them did not work, but only 1 of them worked finally. And then this product, we had CD20, multiple CARs we have tested here. We are only going to show you the data with 4-1BB. So, but here somehow it is written CD28. We also have this one. So we cloned it, And once this plasmid was cloned, and then we put in the third generation lentiviral vector system, so packaged it in using a packaging cell line. We produced a lot of lentiviruses. So now we can generate lentivirus. And I will not go through entire lentivirus process optimization, but just to give you a brief idea that when you optimize this entire process, for the T cell transduction, you require a lot of lentivirus compared to any adherent cell line, which are very easy to transduce. For the T cells, especially the primary human T cells, you require very high amounted, especially very high titer lentivirus. So we optimize each of these steps in the last 3.5 years or 4 years. And then ultimately we can achieve very high titer lentiviral vectors around 10 to the power 8 to 10 to the power 9. This is good for the primary human T cell engineering. Next was we can now manufacture the CAR T from the patient. So again, you go through all these steps. You do apheresis, then you do monocyte depletion, you do T cell activations, then you do T cell transduction, and then expand the cells. Again, I will not give you each detail of it, but this process optimization, again, we did in last 4.5 years almost. All these steps were standardized. Finally, we had CAR T cells from multiple donors. Here we only have, I think, 7 or 8 donors. But we had multiple donors where we can achieve a transduction efficiency greater than 10%, which is, I think, acceptable in clinic. So now we can generate the CAR T cells. And then next question is, are these CAR T cells functional? So are they doing target-specific killing? Are they killing the cells which express the target but do not kill the cells which don't have the target? Are they really cytokines? So basically, are they efficacious? Second question is, can we expand them enough for the clinical dose which is required in the clinic? And can we manufacture these cells, of course, from the patient blood? So all these things we have done. So we have done the killing assays, especially target-specific killing. We use the NALM6, which is representative of BALL, Raji Burkitt's lymphoma, K562 is a CD19 negative clone of the B cell. So what you see here, our CAR T, which are against CD19 target, they can kill NALM6, that means BALL, as well as Burkitt lymphomas, which are CD19 positive, but they do not kill the CD19 negative cells, suggesting that's a target-specific killing. Similarly, we also checked gamma and IL-2 secretion by CAR T cells. Again, what you see is that CAR Ts are secreting a lot of gamma as well as IL-2, indicating that these cells are functional. Now we started recruiting the patient cells, but still the ex vivo study, nothing is going back into the patients, only at the laboratory scale. Okay? So here the data I'm showing only from the one patient where we could see that we can generate the CAR T cells. So these are the patients which are recruited at Tata Hospital, and they are the representative, basically patients who will be benefiting with the CAR T at the later stage. So these are the CAR T we manufacture from the patients. We can show they're efficacious by either the cytotoxic assays as well as for the cytokine assays. Okay. Now the next task was, can we manufacture or expand them in enough numbers in the lab so that they can be infuse them into the patients. So now you can see within 10 days, we can make almost 1 billion cells from where we are targeting only 1 million or 2 million cells. So that means 500 to 1,000-fold expansion we can also achieve from the healthy subjects. Patients is slightly lower, but we can still expand those cells. So as previous speaker was mentioning, that product characterization is also very important to make sure the quality of the product. So similarly, what product characterization means here, that if you want a very good, potent anti-tumor T cells, you need more central memory cells, more stem cell-like memory cells, probably few effector memory, and probably none or negligible numbers of Tregs, right? And also, you need to have not just the T cells, you need to have a proper balance of CD4 as well as CD8 positive T cells. So what we did, we also characterized our product where we see these all CD3 positive cells, what are the numbers and day 8 or day 14 of the expansion. So what you see here, whether it's healthy or BALL, we can have very similar numbers, or like almost half and half. At the day 40, there are CD4 and half of them are CD8. Next, we check stem cell-like memory cells. So stem cell memory in CD4 are RO positive, CD62L positive, 7 positive, and CD95 positive. So these are, we do by multi-parametric flow cytometry. And what you see here, this is gating strategy, don't worry about this. But what you see here, at least 2 to 3% of the cells, even at the day 14, we have the stem cell memory cells in the product after the expansion. Next, we checked central memory. So this is TCM, memory T cell subset. What you see here, even this, we have some these CD4 positive, RO positive, CD62L positive, and 7 positive cells in the product, suggesting that we have a proportion of central memory cells, stem cell-like memory cells in the product. Of course, majority of them are still effector memory, and these cells are expanded in combination of recombinant IL-2 and IL-15. So we are trying to see if by changing the ratio of IL-2 and IL-15 or using the IL-7, we can get higher proportion of the central memory and stem cell-like memory cells. Okay? So effector memory, as I said, there are majority of them are effector memory cells, and very few regulatory cells you see. In the beginning, you have many, but this I don't know why we have higher numbers in the beginning, but at the day 14, and we have fewer number of the regulatory T cells in the product. And regulatory T cells are generally CD4 positive, 25 positive, FOXP3 positive. So what we have is successful process development of the CAR T manufacturing only at the laboratory scale, right? So in the preclinical, we can do it, and now we are doing with the patient work, and ultimately, idea is to do the clinical trials. So basic research is done in last 5 years almost. So now next step is, can we translate this laboratory scale process into the clinical grade manufacturing as per FDA guideline? Because many of you would know that in India, we don't have any regulatory guideline for the CAR T cell work. So we need to have generally when we don't have, our regulatory body is going to tell us use the FDA guideline. So now, as per FDA guideline, generally in Western countries, they do the gas permeable cell expansion bag, which are non-toxic, inert, and gas permeable, but no loss of water. So these are the bags, which are a bit expensive, but we will be using probably these bags for now scale-up, process scale-up. Second, as per FDA guideline, we need to have the release criteria for the vector as well as for the CAR T. So for the CAR T, the release criteria, we have to do these quality controls. So these are the new experiments which are basically making us busy currently. So this is like current focus of the lab. Like we are trying to now doing the assay optimization to satisfy the FDA guidelines. So with this, I would like to acknowledge the laboratory members of my lab, and of course, collaborator Dr. Narula and Dr. Terry Fry from that. So Dr. Gaurav Narula is from Tata Hospital, Mumbai. Terry Fry is from NCI. And the funding majority of the funding comes from the Tata Trust in the lab. And we also now incubated one of the startup for the getting CAR T into the commercialization purpose in our incubator center in IIT Bombay. Thank you.
Thank you, sir, for your wonderful talk and the new era of the beginning of CAR T cells in Indian context. Any last comment from the audience? If there is no more comments, then thank you so much, sir, for your talk. And we would like to thank the organizers, Professor Sir, Bikram Sir, and Professor Biju, and everybody out here for your opportunity to us. Now over to you, sir.
Now we invite Mr. Jacob to briefly discuss on the ASH ISHBT interactions. Mr. Jacob.
Good morning. Thank you so much for attending the ASH ISHBT Joint Symposium. Glad to see everyone. My name is Jacob Kanish, and I work for the American Society of Hematology in Washington, D.C., where I lead global programs. And I would like to take a few minutes to thank our hosts, wonderful hosts, for this opportunity to be here with all of you this week. At ASH, we have developed a number of different opportunities for you to engage and participate in opportunities like the Global Capacity Building Showcase, Global Research Award, Visitor Training Program, to name a few. And these are ways for us to expand our reach and really help with resources to enable education, training, and access to additional opportunities for you to advance. We've partnered with the Indian Society of Hematology and Blood Transfusion for a number of years now, and we're just so excited to be here for another year to develop this joint symposium together, and thanks again for being here with us this morning. If you have any questions about any of the programs that we offer at ASH, just feel free to ask me any questions during the breaks. Thanks again.
With this, we come to the end to the ASH ISHBT plenary session. I would like to thank the speakers and the chairpersons, and we'll start the next session soon.
The next session for this morning is the J.G. Parekh oration. I now invite Dr. Neelam Verma and Dr. Niranjan Rathod to chair the session.
Nancy. It's my pleasure to introduce Dr. J.G. Parekh to the audience, in whose memory this award oration has been instituted. The pioneer hematologist, Dr. J.G. Parekh, he set up the Department of Hematology at J.J. Hospital and Grant Medical College, Mumbai. He obtained his MBBS from Grant Medical College way back in 1934, MRCP London and MRCS London in 1935. He obtained MRCP Edinburgh in 1936, FAMS India in 1961, FRCP Edinburgh in 1967. He was the founder member of Indian Society of Hematology and Blood Transfusion way back in 1950, and he was the founder member of Bombay Hematology Group, which is the most active zonal chapter of our society. That he founded Mumbai Hematology Group in 1976. His contributions to the field of hematology include that he reported the first patient with thalassemia from Mumbai as early as in 1939, as well as the first patient with von Willebrand disease. In recognition of his dedication and love for hematology, his relentless contribution to the science of hematology, the J.G. Parekh oration was instituted by his friends and colleagues. There are two J.G. Parekh orations, one at our meeting at the Indian Society of Hematology Blood Transfusion, and the other at the Bombay Hematology Group Annual Conference. So we are having the ISHBT J.G. Parekh oration now. I would request Dr. Niranjan to introduce the orator for today.
Thank you, ma'am. And it's my proud privilege to introduce Professor Dr. Tejinder Singh. He currently holds position of Senior Consultant Pathologist and Hematopathology and Surgical Pathology at Onquest Laboratories, New Delhi. He is formerly the Director, Professor, Head of the Hematology Section, Department of Pathology at Maulana Azad Medical College, New Delhi. He holds many prestigious awards, honors, and delivered many orations at number of annual conferences across the country. He has written 7 books, published more than 125 papers in national and international journals. He has organized many hands-on workshops at various medical colleges across the country, and I can tell you that he's been one of the loved teacher, and many of the students love his talks. He has 40 years of experience of reporting hematology cases of LN Hospital, Maulana Azad Medical College, and now last 3 years he's been at Quest Laboratories, New Delhi. Now I request Professor Neelam Verma to hand over a certificate of oration to Professor Tejinder Singh. And now we invite Sir to deliver his oration on what is so ominous about dry tap.
Good morning, everybody. At the outset, I would like to thank Indian Society of Hematology and Transfusion Medicine for honoring me with this Dr. J.G. Parekh oration. What I'm going to talk about today is what is so ominous about a dry tap. See, this is the stepwise approach whenever we get a case of hematologic malignancy. First is establish the diagnosis of hematologic neoplasm. Main type of neoplasm, is it leukemia, lymphoma, or myeloma? Identify the WHO subtype, that is the most important thing. Carry out the genetic and molecular markers. And finally, if there are monoclonal antibodies and such receptors are present on these cells or not. So how do we start? The first and foremost thing is clinical picture, peripheral smear evaluation along with the blood counts, special stains, myeloperoxidase, etc., and then bone marrow aspiration. Now what we have to look at is it adequate, is it inadequate, or is it a dry tap? Now what is a dry tap? Dry tap is failure to obtain marrow during bone marrow aspiration. So any condition which leads to hypocellularity, hypercellularity, or marrow fibrosis is likely to result in a dry tap because the increased tissue density of fibrosis or of hypercellularity acts as a mechanical barrier. 93% of the dry taps, which is a huge number, are due to disease of the marrow. Only very few cases are due to technical problem that not conducting it properly. Most cases of the dry tap clinically present with cytopenias, and therefore the marrow evaluation in any case is must. Now in an article by Professor Arbour et al., that how to go about such cases, he suggests that every such case needs a bone marrow trephine biopsy followed by immunohistochemistry. There are 3 main groups of dry tap. First is, and the biggest group is marrow fibrosis. Then we have increased fat in the marrow. And finally, very, very compactly cellular marrow, which results in a dry tap. Taking up the smallest group first, where we find increased fat in the marrow. All of us teach our undergraduates, dry tap, 2 main causes, aplastic anemia or it is a myelofibrosis. Now this is a slide of aplastic anemia where we find replacement of the hemopoietic elements by fat and with few hemopoietic precursors, lymphocytes, plasma cells in the bone marrow trephine biopsy. It needs to be differentiated from hypoplastic MDS, from hypoplastic AML, and then there are certain bone diseases, even renal osteodystrophy may result in a similar picture. Now what is MDS hypoplastic? Now there the marrow cellularity is less than 30%, and this is not a very rare condition. 5 to 15% of the MDS cases do show hypoplasia. Patients have severe cytopenias, and most of these cases are refractory anemia. Now, what is needed is to differentiate it from aplastic anemia are CD34 for the blast cell count, CD61 and CD41 for megakaryocytes and monocytes respectively. This is a picture of bone marrow trophine biopsy in a case of hypoplastic MDS. Now what we find is replacement by fat. Amongst the fat cells, we are able to see few blast cells along with few hemopoietic precursors. So how many blast cells should be there or not? But what we need is actually CD34, because these cells have to be less than 20% to label a case as myelodysplastic syndromes. In a beautiful article by Professor Bennett and Professor Orezi, they have distinguished between hypocellular AML, hypoplastic MDS, and aplastic anemia, and they have laid down very nice criteria how to differentiate the three conditions. What they say is that the aspirate gives undercounts because of the spotty cellularity, fatty marrow, or fibrotic marrow. However, in MDS, in a large series, they say that 3 to 5 cells are seen in the bone marrow fat. However, in cases of AML, the blast cells are arranged in aggregates, and by and large, they contain more than 10 cells. However, they have given a cut line of more than 5 cells are present in small aggregates. And of course, the blast cells are present in an Indian file pattern because of the marrow fibrosis. Now, this is to distinguish from AML hypoplastic type, which was a new entity introduced by WHO in 2008 classification, where we find these aggregates of blast cells. But then we have to confirm that these are really blast cells or not. So what is needed is again CD34, CD117, MPO, these are the stains carried out, and we find that these cells are CD34 positive, confirming that this is a case of AML. However, these are the cases in which we find there is a dry tap. The second group is where the marrow is very, very cellular, very hypercellular marrow, yet we get a dry tap. Now, these are the cases of acute leukemia where it is very hyperplastic. The cells are just packed up, and once you apply suction, they don't get an aspiration. However, biopsy one can carry out. Similarly, lymphomas, which are replacing the marrow, very, very hyperplastic plasma cell neoplasms, and of course, the hypercellular type of MDS. Now, this is a packed marrow from a case of acute leukemia where it is a dry tap. If you do a biopsy, make the imprints, then you can look at the morphology and do even cytochemistry. However, on trophine biopsy, you carry out various markers, both myeloid and lymphoid, and confirm that we are dealing with a case of acute leukemia. Similarly, NHL, non-Hodgkin's lymphoma, where the patients have cytopenias, the marrow is replaced by the lymphoma cells, a similar problem occurs. Then you have to carry out markers for the cases of lymphomas, starting with CD20 and so on. This is multiple myeloma. By and large, multiple myeloma, we find that the aspirates are quite cellular. However, when it is totally packed marrow, one may find that the marrow is hypo in the sense that there is a dry tap. So you have to do the markers for that. Necrosis, whenever the marrow is very, very cellular, the proliferating leukemic lymphoma cells, they compress upon the blood vessels, and the blood vessels get narrowed down, and there is necrosis of the marrow. As and when the necrosis occurs, we don't get bone marrow aspirate. What we find may be some necrotic material, or it is a dry tap. So what one has to do is do multiple sections of the biopsy. One may come across a tiny focus of leukemic cells, and then what we do is carry out the markers and confirm the diagnosis. The third group, the largest group, is fibrosis of the marrow, in which we find the marrow has been replaced by fibrous tissue. You cannot make out the morphology of the cells. Now, these are cases of acute leukemias, myeloproliferative, osteomyelosclerosis, metastatic deposits, multiple myeloma, Hodgkin's and non-Hodgkin's lymphomas, hairy cell leukemia, MDS with fibrosis, and finally osteopetrosis. Now these cases of AML with marrow fibrosis, the list is that what we find is that Professor Orazi has given a review article in which he has given the importance of bone marrow histopathology, that is bone marrow trephine biopsy, multiple sections taken, multiple immunomarkers done, and then you diagnose the disease wherever aspirates and flow cytometry is not possible. What he concludes is that in a fibrotic marrow, we need the blast cell count, and only bone marrow biopsy can give. Pre-therapy bone marrow gives a baseline, that this was the cellularity, this was the baseline residual hemopoiesis, and then post-chemotherapy, we can repeat a biopsy and find out what is happening in the biopsy now. Now, these cases are megakaryoblasttic leukemia, AML, which is secondary to MDS or therapy, then acute panmyelosis with myelofibrosis, and finally AML-NOS, M0 to M6. Now, what is happening in this picture is you find that the reticulin fibrosis is in between the leukemic cells, and that prevents a good bone marrow aspirate. Now, because you find fibrosis and reticulin is markedly increased, and therefore we don't get a good bone marrow aspirate. So what one has to do is markers, CD34, myeloperoxidase, CD13, CD68, CD117, and other markers to diagnose the disease as acute leukemia. Acute megakaryoblasttic leukemias are 5% of all AML cases, and these are seen with Down syndrome or with seminomatous germ cell, non-seminomatous germ cell tumors. Liver, spleen are enlarged. What we find is that the blast cells are more than 20%, and more than 50% should be of megakaryocytic lineage. However, in some of the cases, we do find cytoplasmic budding, which is seen in the bone marrow imprint smears, or it is seen in the peripheral smear. And AML M7 or the megakaryoblasttic is the one where we find marked dyspoiesis of the megakaryocytic series. And then you find the blast cells are seen. Reticulin is seen in between the leukemic cells, and therefore we get a dry tap. And the diagnosis has to be made only after CD41, CD61, or CD42B, where we find that the blast cells are demonstrating a positivity. However, in some cases, we may not see as many pro-megakaryocytes or megakaryocytes. They may be lymphoid-looking cells, but yet they demonstrate CD41 and CD61 positivity. Now, it is uncommon in ALL to see such a degree of marrow fibrosis. But few cases one does come across where there is a marrow fibrosis with acute lymphoblastic leukemia. And again, then we have to carry out the various markers like CD10, 34, PAX5, similarly T-cell markers to diagnose the disease. Acute panmyelosis with myelofibrosis, it is an uncommon form of acute leukemia where we find it is abrupt onset and it is a very rapid fatal course. Bone marrow is a dry tap. And what we find in the trephine biopsy is that there is panmyelosis. All the three series are very, very hyperplastic. And then we find that there is extensive marrow fibrosis, and therefore there is a dry tap. And what we find here, amongst the fibrous tissue, there is a megakaryoblasttic proliferation, megakaryocytic proliferation, erythroid proliferation, myeloid proliferation, and then you find clusters of the blast cells. Now, the count of the clusters of the blast cells is essential to carry out to find out what is the percentage of blast cells in these cases. Now, this is where you find tremendous megakaryocytic proliferation with few blast cells, and this is the reticulin stain to show you the degree of fibrosis which occurs in acute panmyelosis in a very short time. However, the clinching thing is the presence of CD34 clusters, which should be positive to say that this is a case of acute leukemia. And of course, CD61 is going to demonstrate the megakaryocytic series. Going on to MDS, now we know that there are three types of MDS. And what we find is that cases in which there is fibrosis, cellularity is reduced. So the fibrosis, cellularity, and the blast cell count can be assessed only on trephine biopsy. So there are two main types, MDS with hypoplasia and MDS with fibrosis, in which we get the dry tap. Now, cases with marrow fibrosis are not uncommon. 50% of the MDS cases do show some degree of marrow fibrosis. However, 10 to 15% of the cases show grade 2 to grade 3 significant reticulin in the bone marrow, and that is the one which results in a dry tap. Now, this is mainly with therapy-related MDS cases. There is pancytopenia, but what we find is a tri-lineage dysplasia. Erythroid, myeloid, as well as the megakaryocytic, excuse me, they show the dysplasia of the megakaryocytes. Spleen is not there, reticulin is increased. So this is MDS fibrosis. You find fibrosis, and there are these small clusters of blast cells which need to be confirmed with CD34. Then we find that the megakaryocytes, in such cases of RA-EB and therapy-related MDS, the megakaryocytes also show CD34 expression, which is a clinching feature in diagnosis of MDS in these cases. See, the discussion on fibrosis is incomplete without myeloproliferative neoplasms, because they are the ones in which we find a lot of marrow fibrosis occurring, and that needs to be distinguished from secondary marrow fibrosis. The pathogenesis of fibrosis is that the JAK2 and other mutations in myeloproliferative lead to neutrophil and platelet activation. With the result, there is secretion of PDGF, TGF-beta, FGF secretion, which affect upon the marrow stroma, and there are stromal cell and abnormal hematopoietic cell interactions. Certain cytokines are released, and that is the one which results in marrow fibrosis. In primary myelofibrosis, in a fibrotic phase, we come across a typical leukoerythroblastic blood picture with along presence of few teardrop cells. WHO has given beautiful criteria now for distinguishing various myeloproliferative neoplasms, and this is a typical picture from a fibrotic phase of the myelofibrosis. Tremendous fibrosis, but it is yet cellular, and the cellularity is confined mainly to the megakaryocytic proliferation and the myeloid proliferation. The sinusoids are widely dilated. This is a typical picture of primary myelofibrosis. Dysmegakaryopoiesis and the megakaryocytic proliferation is maximum in primary myelofibrosis of all the myeloproliferative neoplasms. And you find the features of dysmegakaryopoiesis. Cloud-like nuclei are seen, wide apart nuclei are seen, multinucleation is present. And then there is a shift in megakaryocytes from the central parts right up to the paratrabecular areas. And change in topography. Dysmegakaryopoiesis is the hallmark of primary myelofibrosis. Reticulin, of course, is increased, and in later stages you find collagenization of the bone marrow occurs. And finally, there is new bone formation. And this new bone formation results in osteomyelosclerosis, and this new bone and the trabeculae may occupy more than 50% of the bone biopsy. And that is what clinches the diagnosis that we are dealing with the case of osteomyelosclerosis. Now, whenever we talk of myeloproliferative neoplasms, this is a picture from Professor Teferi's article, 2014. What we find is that the primary myelofibrosis has got the worst prognosis, ET has got the best prognosis, and the polycythemia vera comes in between. Though all these cases may be JAK2 positive, yet we have to distinguish one from the other because the survival in these three conditions is entirely different. Though we find JAK2 mutation is common, this is polycythemia vera, where it is 90 to 95%. In others, it is 60 to 65%. CALR mutation is in about 35 to 40%. And then there is MPL mutation. Few are triple negative. So one mutation, that is JAK2, It may give rise to polycythemia, it may give rise to ET, or it may give rise to primary myelofibrosis. Now, why does it happen? Now, this happens because of the number of homozygous alleles. If there are maximum in cases of primary myelofibrosis, they are minimal in ET, and intermediate number is seen in cases of polycythemia vera. Now, that determines whether a patient is going to get ET, polycythemia vera, or this patient is going to get a primary myelofibrosis. Now, in these cases, of course, the fibrosis keeps on progressively increasing, especially in polycythemia vera. However, in ET, the fibrosis is rare. The differential diagnosis of PMF is, could it be fibrosis due to PV and ET? Even CML can give rise to myelofibrosis, mastocytosis, MDS, AML, and LPDs. Now, this is a case of CML with myelofibrosis, again with granulocytic proliferation and megakaryocytic proliferation, which the German workers in 90s, Burkhardt and Frisch, said that there is two types of CML. One is granulocytic, the other one is granulocytic megakaryocytic. Now, this entity has now been recognized by WHO 2016 as an advanced cases of CML, where gradually the megakaryocytic proliferation increases, fibrosis occurs, and they go into accelerated phase of CML. In polycythemia, with time, in over a period of 10 to 15 years, what we find is that fibrosis keeps on increasing in the marrow, splenomegaly keeps on increasing in the marrow. So as a result, what happens is because of the fibrosis, there is a post-polycythemic myelofibrosis. And then later on, these patients are in terminal stage, they go into accelerated phase, and finally into a blastic phase. Now, this is post-polycythemic fibrosis. The only difference what we find on morphology is that the erythroid precursors are present as compared to primary myelofibrosis, in which the erythroid precursors are almost not there. And then, of course, there is reticulin, and the megakaryocytes also show dysmorphic picture, and the leukoerythroblastic blood picture appears. Now, this is systemic mastocytosis, where we find the marrow is packed with the mast cells. These are spindle-shaped cells. We cannot make out the granules unless you do Giemsa stain on the imprint smears like this one, where you find halo around these mast cells and confirm the diagnosis that we are dealing with a case of systemic mastocytosis. There is fibrosis of the marrow, which results in dry tap. And then you find these are the mast cells, which you can demonstrate with toluidine blue, as in this particular slide, or systemic, we can do tryptase stain. Hodgkin's disease is one, where we find this is one lymphoma, where aspirate is usually diluted, or you don't find any Reed-Sternberg cells. It is difficult to diagnose unless you do a bone marrow trephine biopsy. Even if the deposit is focal, it does not come, it does not get aspirated because of the associated myelofibrosis. Somehow the disease induces myelofibrosis, and you find diffuse myelofibrosis, or even focal myelofibrosis is a feature. What you have to look for is that usually there is associated eosinophilia, there is plasmacytosis, and then you come across Reed-Sternberg or mononuclear Reed-Sternberg cells are seen, and then you confirm the diagnosis in this fibrotic milieu with the presence of CD15 and CD30 positive cells. Of the NHLs, TNHL sometimes does show extensive myelofibrosis, resulting in a dry tap, but the diagnosis can be confirmed with immunohistochemistry. Hairy cell leukemia is what we teach, that these patients have a typical fried egg appearance. The nuclei are apart because the reticulin is secreted by the hairy cells, and in between the leukemic cells, reticulin is markedly increased, and that results in a dry tap with splenomegaly. Diagnosis now, we have multiple monoclonal antibodies. The two diagnostic ones are DBA44, and then we have annexin A1. The membrane of the hairy cells gets stained, and the positivity of hairy cell leukemia is confirmed, and this is the most specific marker available. Multiple myeloma with fibrosis are quite common. However, it depends upon the degree of fibrosis. And you find that it is a poor prognostic indicator, and it needs to be differentiated from metastatic carcinoma. This is a pleomorphic myeloma, 2 cases where you find extensive marrow fibrosis, and on biopsy also it doesn't look like multiple myeloma. It looks more like a metastatic deposit. So what is needed is CD138. CD138 confirms the presence of the plasma cells, and then anti-kappa lambda. Lambda is totally negative. All the cells are kappa positive, confirming that we are dealing with a case of multiple myeloma. And then we have some non-hematological disorders like sarcoidosis. And these patients will demonstrate the granulomas in the bone marrow, where you find the calcium bodies, and then you find the asteroid bodies, which are Schumann bodies and asteroid bodies, which are diagnostic of sarcoidosis. Metastatic disease. In our country, whenever we have a case of PUO, losing weight, 2 possibilities we think of. One is tuberculosis, for which again we have to do a bone marrow triphyine biopsy to demonstrate a granuloma, or a metastatic deposit. Now, this may not come in the aspirate for the simple reason that tumor cells in about 70% of the metastatic deposit induce desmoplasia of the bone marrow. And that desmoplasia prevents the tumor cells getting aspirated, so you have to do a triphyine biopsy. And then now we put up various markers to confirm if it is an unknown primary. All these cases have to be distinguished from primary autoimmune myelofibrosis. Now, this is seen mainly in collagen vascular disorders like SLE, and you find there is extensive marrow fibrosis, again resulting in dry tap. But what we find are leukoerythroblastic picture, intense marrow fibrosis. There are few lymphoid aggregates, complement level is low. So you have to combine the clinical picture along with the histological picture. And what you find is that the megakaryocytic proliferation is missing, unlike any myeloproliferative neoplasms. In children, we find presenting infants with massive spleen, and then you find bone marrow aspirate is a dry tap, and what we find on triphyine biopsy is osteopetrosis. Now, this osteopetrosis is because of the fact that the osteoclasts, they fail to resorb the osteoid which is getting deposited. So there is a unruly bone formation which occurs. There is extensive marrow fibrosis, and that leads to osteopetrosis. Since there is no marrow in this, marrow starts forming in the spleen, resulting in a massive splenomegaly, and the liver gets enlarged, and we have osteopetrosis occurring in infants. So to conclude, whenever we get marrow fibrosis, what we have to look for, a clue in the marrow morphology, which may guide us which markers to put up. It could be the cellularity, it could be the hyperplasia, which cell lines. Is it unilineage, bilineage, trilineage? Are there monomorphic atypical cells? Maybe acute leukemia. If there are monomorphic lymphoid cells, we have lymphoproliferative. If there is a nodular deposit with some large Reed-Sternberg-like cells, it could be Hodgkin's disease. Then about the megakaryocytes. Are they in clusters? Are they scattered? Is there any heterotopia? Is there any dysmegakaryopoiesis or not? So as to distinguish the various myeloproliferative neoplasms and also conditions like acute panmyelosis with myelofibrosis. Therefore, in a dry tap, it is mandatory to carry out a bone marrow triphyine biopsy, since it indicates that there is a diagnostic alert for a clinician that majority of the cases of a dry tap have a hematological malignancy in the marrow. And therefore, triphyine biopsy with immunohistochemistry is the answer to diagnose such conditions. Thank you very much.
Thank you, Professor Tejinder Singh, for a wonderful oration. This was a perfect ode to the memory of Dr. J.G. Parekh.
Thank you.
I like to thank the organizers for inviting both of us to chair the session. Over to the organizers. Thank you.
I thank Dr. Tejinder Singh and the chairs for the session, Dr. Neelam Verma and Dr. Niranjan Rathod. Before we adjourn for coffee, a few announcements. There are limited seats available for Meet the Professor session, so you're requested to write down your name under the name of the expert you would like to meet. These boards are placed near the registration area. All the delegates whose abstracts have been selected for oral presentations, you're requested to kindly upload your presentations in the...
We had to do marker studies, immunohistochemistry and all, just to differentiate between... Yeah, it happened today. Somebody came and banged me on the back. Then he says, sorry, sir. I wanted to hit him, not you.
The session begins now.
Thank you, madam.
All sessions will start and end on time.
Good morning, ladies and gentlemen. This is the first time I'm in Kochi. I didn't know what backwaters was. Somebody told me it's a water body linking the ocean. And our hotel is right band on the backwaters. So coming back to hematology, today we have a session on hemoglobin disorders, and along with my co-chairperson, will take on this session. The first speaker is Dr. Tufan Dolai, and he'll be talking to us on iron overload in thalassemia. How do you monitor? And how do you treat this? Now, Professor Dolai is Professor of Hematology at NRS Medical College in Kolkata, the land of Mamta Didi. He is a skilled hematologist who's been in the field for the last 17 years. He has published more than 50 papers, both in international and national journals, and has carried out a lot of multi-centric trials. He has contributed a lot of chapters to various books. Now, may I request Dr. Dolai to kindly give his talk, please.
Good morning, respected chairperson, ladies and gentlemen. And thanks for the organizer for giving me the opportunity for speaking on the iron overload in thalassemia, the monitoring and the treatment. And this is basically the vast topic. Within 20 to 25 minutes, I try to cover this topic by the brief overview of this iron overload in thalassemia, the monitoring and the treatment. My outline of the talk will be on the iron toxicity. Iron is very important in our body, but when it is overloaded, there will be toxicity. And there will be a little bit of the problem of the iron overloaded. How do you monitor the iron overload? And what are the different chelators available and their efficacy? And what are the new upcoming agent is coming for the treatment of the iron overload? As you know, the thalassemia is basically divided into the two aspects, the transfusion dependent thalassemia and the transfusion independent thalassemia, or we call the NTDT. Both the condition has a different pathogenesis and there is a different clinical scenario. But in general, both the condition can give rise to the iron overload in the different pathogenetic mechanism per se. In our body, the iron is a very essential component. It is in some metabolic component, there is a storage component and also the transport component. In terms of the metabolic component, this is very essential in our body that plays the major role for the different metabolic process, different enzymatic pathway and different other pathway that is very, very essential in our body for maintaining our normal homeostasis in our body. And iron have been distributed throughout the body, but the important thing is that our body has a mechanism for the absorption of the iron, transfer of the iron, store of the iron, but unfortunately, there is no mechanism for the excretion of the iron is there. So when the iron has been accumulated in the body, our body don't have any mechanism for the excretion of the excess iron in the body. So in the thalassemia, the iron overload is basically due to the blood transfusion and due to the increasing iron absorption from the intestinal systems. So in thalassemia major, the transfusion-dependent thalassemia, the patient have been receiving the repeated blood transfusion. So one packet of the blood transfusion is contain around the 200 milligram of the iron. In 20 kg child, in 1 year, there is a 2.3 gram of the iron overload will be there. So can you imagine? So that continuously the blood transfusion is going on and leading to the iron overload in patient with thalassemia. In terms of the beta thalassemia, the hepcidin play the major role for the iron absorption also. In beta thalassemia major, apart from the repeated blood transfusion, there will be the down regulation of the hepcidin. Then there is increasing intestinal iron absorption and also the release of the iron from the reticular endothelium system leading to the iron overload in case of the beta thalassemia. So beta thalassemia or the transfusion dependent thalassemia along with the recurrent blood transfusion, the down regulation of the hepcidin is important pathway. Whether in case of the non-transfusion dependent thalassemia, the GI absorption play in the major role for creating the iron overload state into the body. Here also there is a down regulation of the hepcidin by increasing HIF and increasing GDP factor and ultimately leading to the more iron absorption and they become accumulated in the liver and into the heart and also the different endocrine organs. When there will be repeated blood transfusion, our body is trying to compensate but unable to excrete it. So recurrent blood transfusion leads to saturation of the macrophages and there is a saturation of the transferrin which is the protein bound by the iron and ultimately there is a formation of the non-transparent bound iron and this non-transparent bound iron has become deposited in the parenchyma or the different organ that leads to the problem in our body. And in the intercellular, there is a labile plasma iron is also there. So both into the extracellular and in the intercellular, they causes toxicity and ultimately leads to the problem into the pituitary, in the parathyroid, there is a heart, liver, pancreas, gonad, and the bone marrow. And it basically causes the Fenton reaction and leading to the reactive oxygen species formation. And this reactive oxygen species lead to the lipid peroxidation. There is a loss of mitochondrial membrane, there is loss of respiratory enzyme, there is increasing lysosomal fragility and apoptosis, and ultimately leads to the lot of morbidity and the mortality in patient with thalassemia due to the iron overload. As the transfusion is going on, there is accumulation of the iron is going on over the years. A lot of the problem can suffering from the thalassemia patient, but at the end of their life, majority of the patient, they died due to the arrhythmia, due to the heart failure, and also the cirrhosis of the liver due to the iron overload status, and leading to the lot of morbidity, both into the transfusion dependent as well as the transfusion independent of the thalassemia. The sum of the complication is unrelated to the iron overload, but the majority of the complications are due to the iron overload in patient with thalassemia. That's why the iron chelation is the essential component for the treatment with the thalassemia patients. Before going to the treatment proper, how do you monitor it? Whether the patient has been suffering from the iron overload there or not. So there's a lot of tools is there for the monitoring of the iron overload. There's an invasive technique is there, there's a non-invasive technique is there. Basically the liver biopsy, previously we did it, but nowadays due to the lot of the non-invasive technique, the liver biopsy is not done nowadays. The serum ferritin, the MRI of the liver, MRI of the heart, the squid, this is a very important tool for assessing the iron overload. In terms of the liver, apart from this, the biopsy, the enzyme, the USG, which is the more easily available, and also sometimes the viral marker can play a role in the hepatitis. But the MRI, the R2, and the MRI T2 star, fibroscan, and the squeeze technique is the important tool for assessing the iron load into the liver. Depending upon the availability of the techniques and the tool you may use it in your clinics. In terms of the cardiac iron overload, the MRI T2 study is a very important tool for assessing it, and for diagnosing for the arrhythmia, the ECG, the Holter monitoring, echocardiography is also important tool for establishing the iron overload. Apart from that, there is a growth monitoring, the sexual development monitoring, different endocrine parameter, the DEXA scan, and the more and more so is that psychosocial assessment of the patient and the family is important monitoring technique for detecting the iron overload in patient with thalassemia. Some are directly related and some are the indirectly related for the assessing of the iron overload. Come by one technique in terms of ferritin estimation, which is a very simple tool, which is a surrogate marker for the iron storage. They have a lot of advantage and the disadvantage is there. The major advantage is the easy available. That is very inexpensive. We can follow the continuously, the longitudinal follow-up. But the major drawback is that there is a fluctuation of the serum ferritin due to the inflammation and there is abnormal liver function. Sometimes the vitamin C deficiency can give rise to the falsely high value of the serum ferritin. So the interpretation of the ferritin value has to be done judiciously before diagnose that patient has a iron overload is there or not. In terms of the liver biopsy, previously we did it by the histopathology, the iron staining, and the quantification of the iron parameter has been tool for estimating the iron overload into the liver. There is a lot of advantage and the disadvantage is there. Nowadays, the liver biopsy is not a standard technique. The major disadvantage is that there is an invasive procedure, the pain-filled procedure, there is a chance of bleeding is there, and even into the chance of mortality is there. That's why the liver biopsy tool is not important tool for the diagnosis in nowadays. But for the assessing the iron tool in case of the liver, there is for milligram of the gram of dry weight is the very important. If the liver iron concentration is more than 50, there is a chance of cardiac iron overload is together is also there in case of the liver biopsy technique. In terms of the MRI tool for assessing the liver iron is a very, very essential tool. The R2 that is called the ferric scan is preferable to the R2 because it's the more robust technique. There is the software is there. But the important thing is that the MRI liver iron concentration should not be used interchangeably across the institution. There is a lot of inherent problem per se for the estimating the liver iron concentration into the liver. There is several advantages for estimating the in our country. The important thing is the cost issue is the very, very important, and the disadvantage is that it is indirectly measure the liver iron concentration in case of the iron overload. In terms of the cardiac iron overload, also the MRI is the gold standard tool for assessing the iron responses. There are two pictures is there depending upon the T2 star value. We can call patient as iron overloaded. In that, there is a black area is called the iron overloaded, and it become there is relaxation time is the very, very important. If it is more than 20 milliseconds, we are happy. If it is less than 20 milliseconds, so there is a chance of iron overloaded is there in terms of this MRI technique. In the MRI technique also in the cardiac, there is the advantage and the disadvantage is there. The important advantage is there, both the liver and the heart we can see together, and also serially we can follow it for assessing the iron overload in case of the cardiac. And the major disadvantage is that there is a cost issue also important, the availability of the machine, and also the software, and also the person behind the machine is also important for assessing the iron overload in case of the liver. So in general, for the T2 star imaging, if the less than 6 milliseconds, we call severe iron overload. If it is 6 to 9 milliseconds, we call the moderate. If it is less than 10 to 19, we call the mild iron overload. If it is 20, we are happy that there is no iron overload there in case of the heart. There is another technique and tool is there. This is called the superconducting quantum interval device is there. This device is not available in world. There is a few machines available is there. And another is the cost issue is concerned in terms of the superconducting device. So routinely we are not using and not advocated for estimating the iron overload. To summarize, the liver iron concentration by the MRI technique, liver iron concentration by the cardiac in the MRI technique, the T2 star. In the liver iron concentration, if it is more than 15, there is a severe iron overload in the liver. More than 7 to 15, it is called the moderate. 3 to 7, it is mild. And less than that, we call the mild iron overloaded. In terms of the myocardial iron overloaded, the T2 star value, it is more than 20, we call there is no iron overloaded. If it is less than 6 milliseconds, there is a severe iron overload is there. So for the technique is the MRI, gold standard, but availability is the major issue. So the ferritin is also there. If it is more than 1000, we call there indication of the chelation is there. If it is more than 2500 is there, there is a severe cardiac iron overload status is there. So we have to monitor judiciously depending upon the availability of the tools and the technique in your institution. If there is a echocardiography technique is there, the USG is there, you follow it. If you have availability for the MRI technique, you follow it. But the gold standard is nowadays is the MRI for estimating the liver and the cardiac iron estimation. At least we have to be done annually. But recently there is a guideline has been published, will be published soon in the blood journal in terms of according to the different ages, though there is that busy slide is here. So for the monitoring, the serum ferritin has to be monitored every 3 months at least. possible, then liver enzyme has to be monitored. And apart from that, there is a cardiac, the MRI, there is a liver, and also the fibroscan, the enzyme, all has been given the guideline depending upon the situation. If you have a severe iron overload, so you have to monitor more frequently, the 6 monthly. If there is a moderate, you have to monitor annually. If it is mild, then you have to monitor every 2 yearsly. So you can go through it. There is a beautiful, will be published into the blood journal in the soon. Little bit about the treatment of this, the iron overload. So the indication of the iron overload treatment over the different guidelines is, there is no major differences, but in general, if it is more than 1,000, you have to give the iron chelating agent, or there is a 10 to 20 transfusion is there. Indication in case of the non-transfusion dependent thalassemia is more than 800 is there. So we have a three main oral iron chelator is there. One is the both subcutaneous and the IV. Another is the defriprone and the deferasirox for the oral preparations. We have more experience in the desferrioxamine, but the deferasirox is recently from the 2005, which becomes very effective for treatment of the iron overload. Basically, they become chelate to the metal iron and leading to the excretion through the urine or through the feces, and that leads to the decreasing serum ferritin or the overload status in our body. And basically, our principle of the iron chelation is that both the over chelation and the under chelation has become harmful. So we have to be balanced properly, that the more chelation leading to the also more problem. And the important thing is that our main goal will be the safe iron balance in the tissue, because iron is also the essential component in our body. And also we have to detoxify the iron, not only in the intracellular, but also the extracellular component is also there, and also the complex formation is there. We have to remove the iron from in our body. But we have to balance properly. The too much iron is also become dangerous, and the too much chelator, that can lead to the neurotoxicity, the growth failure, and there is a lot of problem is there. So we have to be balanced properly for the chelating of the iron. So we have available chelator is the desferrioxamine called the hexadentate, the deferasirox, the tridentate, and the defriprone. There is a bidentate chelator is there. Though there is a definition of the ideal iron chelator, the none of the chelators becomes fulfilling the criteria of the iron chelator, and the deferasirox is slightly following the ideal iron chelator. This is the overview. I am not going into the details, but important thing is that the starting dose is 20 to 60 desferrioxamine, defriprone is the 75 to 100, and the deferasirox is 20 to 40. There is several trial for the cardiac iron overload is there. There is several trial in case of the liver. I am not going into the detail, and also the endocrine. But if you go to the summary of this slide for the all iron chelator, the desferrioxamine basically for the transfusion dependent thalassemia, it reduces the serum ferritin, the liver iron concentration, improvement of the cardiac C2 star, and also the cardiac dysfunction. Defriprone is the more effective for the cardiac iron overload. You are usually in the combination with the desferrioxamine, and the deferasirox also for the reduction of the serum ferritin, the liver iron concentration, the improvement of the hepatic fibrosis, and also the stabilization of the heart failure, and also the endocrine function. The deferasirox becomes very useful. In terms of the entity, the deferasirox has a long-term data for reducing the serum ferritin and also the liver iron concentration. But there is a few limitation is there for the current available chelation, particularly in case of the desferrioxamine, which is parenteral. The adherence is the main problem. Also the issue in terms of the availability of the pump is also the important issue. In terms of the defriprone, there is side effect profile, the neutropenia, and all those things has to be monitored carefully. In terms of the deferasirox also for the availability, in terms of this, the palatability of the compound and adherence to the children and leading to the GI symptoms becomes major concern. That's why there is a recently the film-coated new tablet formation of deferasirox is available. We call the ECLIPSE study. This is the design of the study, and there is starting dose is there is a 14 mg per kg per day of the deferasirox. If we go to the result of this study, the patient reported adherences, satisfaction, patient reported concern, and also the palatability, the GI symptom, and also the best type of the medicine, the film-coated tablet is superior than the normal tablet available. So the film-coated tablet of the deferasirox is one of the treatment option for the iron overload patient, particularly in case of the GI intolerances. In terms of this, the newer therapeutic technique, there is a few things is there for the ineffective erythropoiesis. They are called the sotatercept and the luspatercept. Though they are indirectly inhibiting the tackling the iron overload, directly the mini-hepcidin and the tryptase inhibitor is there. They are basically the sotatercept and the luspatercept. They are acting on the GDP receptor and also the the mini hepcidin and also the temperase inhibitor, basically they are acting onto the hepcidin, leading to the upregulation of the hepcidin. So basically the sotatercept and the luspatercept, both the molecule, they are basically the stabilizes the RBC and also the increasing the differences of the RBC, leading to the less transfusion and also the less iron overload into the body. So in the future, they are indirectly reducing the iron overload. They have a phase 2 data is also there, both into the luspatercept and the sotatercept for the reduction of the iron overload into the liver is there. In terms of the hepcidin is the major player for the iron regulator. So by doing these two things, the mini hepcidin and also the temperase inhibitor, both can upregulate the hepcidin in terms of the treatment of the iron chelation. The mini hepcidin is basically the small peptide. The temperase inhibitor basically the antisense oligonucleotide and small RNA that stimulates the endogenous hepcidin production. And they have also the preclinical data is also into the mouse, both the mini hepcidin and these things, and they becomes effective for the iron overload reduction, the anemia, and also the ineffective erythropoiesis for the treatment of the iron overload in patient with thalassemia. But in your clinics, you have to follow it. In terms of the TDT and the NTDT, when to initiate the iron chelation, if it is ferritin is more than 1000 in case of the TDT, and NTDT if it is more than 800. For the intensification of the chelation, if it is more than 2500, if the liver iron concentration is more than 7, then you have to use it. And also we have to give the double chelation if the ferritin is very low or there is a severe iron overload in case of the liver and the cardiac estimation. In terms of the initiating the chelation therapy, this is the Canadian guideline is very good. If the patient has a more than 1000 ferritin, if the liver iron concentration is more than 7, then you look for the cardiac T2 star. If the cardiac T2 star is more than 20, then we can use the desperioxamine or the deferasirox. But in terms of the cardiac iron overload status, the defriponis becomes better. And if it is more than 2500, the LIC is more than 7, then combination of the defripon and the desperioxamine and other combinations should be used in your clinical practice. But you should not forget the side effect of the chelator. So you have to monitor the neutrophil count weekly, and you have to monitor the creatinine, particularly in case of the deferasirox, and also the liver enzyme monitoring, and also the pyrotony and the ophthalmoscopy annually, both into the defriprom and the deferasirox during the treatment of the chelation. So in take home, the iron overload causes substantial morbidity and the mortality in case with thalassemia. Toxic effect of the iron lead to dysfunction on the heart, liver, and also the endocrine gland. The reactive oxygen species that leads to the cellular dysfunction, the apoptosis, the necrosis that translate to the target organ damage and the dysfunction. Serial serum ferritin estimation is a tool along with the MRI technique for the liver and the cardiac iron estimation. More recently, the film-coated tablet is available, but the effective iron chelation will improve the survival in patient with thalassemia. Before concluding, I have a 2 to 3 more slides for regarding some announcement. In the Bengal Society of the Hematology for 16th and the 17th February, we are doing the Professor J.B. Chatterjee Centenary celebration. Dr. J.B. Chatterjee is one of the scholar in the field of the hematology, and hematology of the Kolkata is started, in India is started from the Kolkata. And also there will be Hope Asia 2019, will be in the Kolkata 23rd to 25th August 2019. So I all welcome you to participate in this event. Please keep the date blocks. And subsequently the Haematocon 2020 also will be in the Kolkata, the 5th to 8th November 2020. So please keep the date block. And we are welcome you in advance for attending the Haematocon 2020. Thank you very much for patient hearing.
Thank you, Dr. Tufan Dolai, for the excellent overview of a topic which is of concern to all practicing physicians and hematologists. Thalassemia is a disease which can be easily prevented. Cyprus, a small country, has prevented it. You need marriage counseling and all those things, but somehow we as practitioners and our government has not been able to do that. I appreciate you finished on time. Thank you so very much. Now, the topic is open for discussion. Any questions, please? Please go ahead. Yes, madam. Please come up to the mic. Yeah, go ahead.
Nice
please
overview.
Please introduce yourself and your institution.
My name is Sunil Bhatt. I am from Narayana Health City, Bangalore. Nice overview, Professor Dulai. I have a couple of questions. One is, I don't think you touched on the combination chelation, and especially with the more and more data coming with the differential activity of the different chelators. So I think this concept of combination chelation is emerging, especially, and I wanted to know your views on, especially oral combination chelators, some data out there. That was one, and I think first you can take that.
This is a very important question. Due to the paucity of the time, I'm not unable to cover it. But in one slide, I show you that for the intensify the chelation, if the ferritin level is 2,500 and the LIC is more than 7, then you have to use the combination of the ion chelation therapy. So we have a 3 combination is available. Both oral combination is there. The desferrioxamine and the defriprone is there, and also the desferrioxamine and the deferasirox is there. Which chelator has to be used? The cardiac T2 star value is ideally detected. Suppose if your cardiac T2 star is more than 20, then you can use the desferrioxamine and the deferasirox, or you can use the desferrioxamine and the deferasirox. But if you have a cardiac iron chelator status means cardiac iron status is very poor, it is less than 20 milliseconds, the defriprone has to be used. There are more experiences in terms of the desferrioxamine along with the defriprone. So you have to be used in terms of the cardiac iron overload status. If the liver iron is more, there is no cardiac iron, then there is a desferrioxamine along with the deferasirox will be the option for the treatment in case of the combination agent in iron chelator.
Yes, madam. There was a lady. Yes, madam.
I'm Dr. Sheila, Associate Professor of Trichur Medical College, Pediatrics. I was about to ask the same question because we have 21 patients on deferasirox now, chelation, and 5 or 6 patients have always elevated levels more than 5,000 even, 7,000 and all. And we used to give 4 to 5 days IV desferrioxamine, but the same 2,000, 3,000, like that it is persistent. And in our setup, we can do only this ferritin estimation, and myocardial performance index, we don't know how to. So we are giving deferasirox maximum dose 40 milligram per kg per day. They don't have much toxicity, but I would like to know about combining this deferiprone. At least in a few patients can we do like that, and how to do almost daily giving both. These are my doubts.
So the thing is that a very important question. The majority of our patients, they came late, their ferritin level is very high, and we are unable to control with a single agent, so we have to be use the double agent together. If the facility of estimating the MRI with liver and the cardiac is not available, the other tools and techniques which is available in your institution, like the liver iron for the enzyme, the USG, the fibroscan is available. So you may have get some knowledge for the liver iron concentration. So if the liver iron concentration is there, then you can use the desferrioxamine and the deferasirox together. So you have to use the desferrioxamine. You can escalate the dose up to the 80 mg per kg per day also, and you have to be given at least for the 5 to 7 days. 5 days at least to be given, but you may give up to 7 days also. In terms of the deferasirox also, we have to increase the dose up to the 40 mg per kg per dose has to be given combination throughout the means the 7 days. Ideally, we give the 7 days and the 2 days gap of the desferrioxamine, and you have been giving continuously the deferasirox. In the other hand, if there is the cardiac iron overload is more, by doing the ECG, the echocardiography, or you can do the tricuspid regurgitant jet velocity, we have an indirect estimation that patient has a iron overload along with the pulmonary hypertension. In that scenario, we directly use the defriprone and the desferrioxamine together. So you may increase the dose of the defriprone up to the 120, 100 and 120 also. And the desferrioxamine, I already told you, up to the 80 mg per kg, we can use it. If it is still not controllable and the cardiac arrhythmia is there, you may use the continuous infusion of the desferrioxamine.
Thank you, Dr. Tufan Dolai, for the excellent talk, and I'm very happy that the audience has participated. Over lunch, please. No more questions. We are out of time. Over lunch. I hand over the mic to my co-chairman, please.
So we move on to the second presentation on genetic diagnosis of hemoglobin disorders by Dr. Shaji RV. Sir is actually the professor of molecular biology in Department of Hematology and adjunct scientist at Center for Stem Cell Research at CMC Vellore. His areas of interest in hematology include genotype, phenotype, correlation of hemoglobinopathies, and Fanconi anemia. He's also interested in developing new molecular diagnostics methods for inherited hematological disorders. Over to you, sir.
Thank you for the introduction. I really can't start my presentation thanking the organizers because I'm one of the members in the organizing team. So in the basics, in the beginning, I'll just go through some basic slides about hemoglobinopathies. And subsequently, we will move on to discuss the different techniques and different methodologies that are available for the diagnosis of hemoglobinopathies, especially thalassemias. And the last few slides, I'll explain some of the exciting new technologies that are available for efficient diagnosis of hemoglobinopathies. So since I see some students in the audience, I'll just go through the basics in the first few slides to say that we have two globin clusters. One is an alpha globin cluster, and the other one is beta globin cluster. And we have three predominant hemoglobins produced during development. In the embryonic stage, one particular hemoglobin that is produced is zeta 2, epsilon 2, and subsequently in the fetal stage, gamma 2, alpha 2, and in the adults, we have alpha 2, beta 2 predominantly. Just to say that because we'll be going to talk about these different types of hemoglobin in the subsequent slides, and it's important to know what are the important three different hemoglobins produced during development. Just a short introduction on thalassemias. We know that thalassemias are quantitative disorders of globin chain synthesis, and it causes imbalance in globin chain. And the major two types are beta thalassemias and alpha thalassemia. And beta thalassemia is due to mutations in the beta globin gene, and alpha thalassemia is because of the mutations in the alpha globin gene. And when you do a larger screening
Just a minute. People at the back, please come ahead. There are a lot of chairs here. Please come. Come. Please come. Come. There are a lot of chairs here. Please come. Go ahead, please. Sorry.
It's not only alpha thalassemias and beta thalassemias. You will see when you start molecular diagnosis of thalassemias. And you will see a large number of cases where both delta and beta globins are deleted. And these are called delta beta thalassemia. And some cases, they are called hereditary persistence of fetal hemoglobin. Depending on the phenotype these patients show. And these are the basics. With that, we'll just move on to talk about the laboratory diagnosis of thalassemias. I'm going to focus on genetic diagnosis, but it's important, it's very, very important that we can't perform genetic diagnosis without a few other lab tests, which include the complete blood count, including MCV, and subsequently, you have to have hemoglobin F, A2 values documented before taking the samples for genetic diagnosis. And this is, I'm not going into details, and we all know that we have to look at the hemoglobin A2 levels and F levels, and we have to see whether these patients have any other abnormal hemoglobins, including hemoglobin S, E, LEPO, hemoglobin D. They all have to be documented. And variant hemoglobin HPLC analysis is quite handy, and it's an absolutely necessary equipment before doing any DNA test, and it can differentiate heterozygous beta thalassemia, homozygous beta thalassemia, HBE beta thalassemia, S beta thalassemia, and many other different subtypes of thalassemias. And we know why we have to do molecular diagnosis, because we may get sometimes transfused patients. We have to do a diagnosis, and we can't do a hemoglobin analysis. We have to do DNA analysis, and then we require molecular diagnosis and unusual levels of hemoglobin F and A2 levels. And when you have a large number of cases, you will see unusual F and A2 levels, and sometimes it's very difficult to stop with the usual tests and really have to do a molecular diagnosis and tell the family what exactly the molecular defects are. And DNA analysis definitely helps in the prenatal diagnosis. And there are many centers in India now doing prenatal diagnosis for thalassemias. And for that, we definitely have to do DNA-based diagnosis. And sometimes you get patients with severe homozygous beta thalassemia, mild homozygous beta thalassemia. Occasionally, clinicians may require this information, why these patients have severe phenotype or milder phenotype. And in HPLC, we may get unknown peaks, and we may have to do a molecular diagnosis and see what mutations produced these globins. So now the textbook says that there's definite values for hemoglobin A2 and F to look at. And I just put together some 1,500 cases of heterozygous beta thalassemia in the last 3 years. And you can see the wide spectrum of the values in the hemoglobin F and A2. And I'm not going to these heterozygous beta thalassemia individuals where we can't talk about the clinical reason for high hemoglobin F. There may be other underlying pathology behind that. However, if you see there's a large number of heterozygous beta thalassemia have got hemoglobin F more than 3%. And you can also see here that there's a large number of heterozygous beta thalassemia have hemoglobin A2 more than 6.5. These are unusual values. And you can see here that a large number of heterozygous beta thalassemia individuals have hemoglobin A2 less than 3.5. And when hemoglobin A2 is less than 3.5, it's very difficult to do the diagnosis. And when you have hemoglobin A2 more than 6.5, you really have to see a molecular diagnosis and see what exactly has caused the increase in the hemoglobin A2 levels. This is to tell you how important sometimes to do a molecular diagnosis and see why some patients carriers shows some values like that, some carriers shows, and it is not just for academic reason alone. And just to go through, and when you have a wide spectrum of hemoglobin F and A2, especially for a lab like ours, when you get large number of patients coming in, we try to make sure that molecular diagnosis is done for almost all cases. We had to look at hemoglobin F levels, A2 levels, why is it low, why is it high, what's the molecular basis of that. And I'm not going through the details here. I'm sure that 90% audience know what are the common methods used for the molecular diagnosis of beta thalassemia. Reverse dot blot is one of the most common method that is used for detecting the common mutations, where the probes specific to the mutant and wild type sequence are immobilized on the membrane, and the PCR product is hybridized, and it's checked whether it binds or not. And we can discuss the details of the methodology if required later. And the other popular method is amplification refractory mutation system, which use allele-specific primers to detect the mutant and wild-type sequences. And these two methods are the two methods which are commonly used in most of the Indian labs. And this covers around 80 to 90% of thalassemia cases in the country. And in some populations, 619 base pair deletion is very common, and using a PCR-based method, we can see whether the patient has 619 base pair deletion or not. So using this, using reverse dot blot or ARMS with a 619 base pair deletion, it's possible to get 80 to 92% of the cases of thalassemia cases sorted out. Then in those cases, we don't see the mutations, and almost all labs, I think every lab, takes the samples for DNA sequencing to see whether these patients have some of the rare mutations. Because reverse dot blot and ARMS, they detect only the common mutations. And 619 base pair deletion is one particular mutation that we look at. So with all this, using the common mutations, then going to sequencing, we had realized that is how important sometimes, case to case, we had to do the comprehensive molecular diagnosis here. And this is one of the very important group of patients that we found is a de novo dominant beta thalassemia. And the patients presented with hemolytic anemia, and they had inclusions, And we could not detect any other genetic abnormality at all. And we sequenced the beta globin gene in these patients, and we found that these patients had mutations in exon 2 and exon 3. And we know that these mutations in exon 2 and exon 3, if they do not make a truncated beta globin, and if it runs through and go to exon 3 to make the beta globin peptide long enough to make a heterodimer with alpha and heme, it can still make an abnormal hemoglobin. And this was not detected. We don't know the reason, but when we do a HPLC analysis, we could not see high hemoglobin A2 levels. And this is because it's an abnormal hemoglobin that is produced. It is a quantitative disorder. It's not a qualitative disorder. And it was a very important finding that we had in the lab. And this, we could do it because we had all these comprehensive methods in the lab that we developed over a period of time. And we can routinely do the diagnosis of silent beta thalassemias. And one of the parents, father or mother, may have normal hemoglobin A2 levels. And the patient comes with the phenotype thalassemia intermedia, and one of the parents you see has got normal hemoglobin A2 levels, and DNA sequencing has helped us to find out the patient's father or mother with normal hemoglobin A2 had a mutation that causes silent beta thalassemia, and which was the capsid mutation. And again, this methods all helped us to identify each and every case of different types of phenotypes that we had from patients. So this is a case of high hemoglobin A2 homozygous beta thalassemia. We don't expect hemoglobin A2 to go up beyond 4, very rare, in homozygous beta thalassemia. We occasionally get patients with high hemoglobin A2, sometimes it's more than 9, going up to 14. And we sequenced and found that it is typically because of a mutation in the polyadenation site. And it could give us so much information why the patient had an abnormal hemoglobin pattern, and we could show that it is because of one particular type of mutation. And sometimes abnormal hemoglobins, hemoglobin lepore, and that could be detected. And please stop me if you have any questions, or you can ask the questions towards the end. What I'm trying to say is that comprehensive methods really helped us to do the diagnosis for every case in the lab. Sometimes we get homozygous beta thalassemia with normal hemoglobin A2 with low AMCV, and it's not a silent beta thalassemia because the heterozygous carrier has low MCV, and we found that in addition to the mutation beta thalassemia, there was a mutation delta that prevented the increase in the levels of hemoglobin A2. And now I'm just going to a different class of thalassemias. I said it was a delta beta thalassemias and HPFH, and this we get, even when you do a large number of patients screening for HPLC, you can get sometimes with carriers with high levels of hemoglobin F. And you can see here on the left side is a delta beta thalassemia, and the other side is hereditary persistence of fetal hemoglobin. And you can see there's relatively more hemoglobin F is seen in the HPFH group, and it is important to do a diagnosis and see what is the genotype in this patient. And we know that the 2 mutations in the Indian population cause this phenotype, and we screen in the beginning only 2 common mutations, and this could cover up to 70 to 80% of cases of delta beta thalassemia and HPFH in the patients who had high hemoglobin F, the parents of the patients who had high hemoglobin F. And subsequently, we took an effort to make sure that we have to have a method to detect all cases of delta beta thalassemia and HPFH, for which we developed a quantitative fluorescent PCR method. It's a very easy technique to do, and we used it for several years, and it works very well. Here, the primers binding to the gamma globins and beta and delta, and amplify the PCR product, run through a DNA sequencer, which works as a capillary electrophoresis, look at the peaks, and decide what is the peak height, based on which we'll be able to say whether the patient has got any deletion in the region of delta and beta globins. And please ask me any questions during lunch or something. We don't have much time. Sorry, rushing through this. And we could do the diagnosis for almost all the cases of delta beta thalassemia and HPFH using this method. And we found that it's highly reproducible. We were really scared whether it will be really reproducible or not, but we've been using it for 18 years, so 8 years now, and it really works, and almost in all cases, we could do the diagnosis here. But because when we use this gene dosage analysis, it does not say where is the break point, where it starts, where it ends, and the new, recently newer method called MLPA, and we started using this, and this can be used for identification of the deletion to see where is the break point starting from and where it is ending. And it's a very important technique. Again, I can't go through the basics to explain this. And using this, we could see this, the first patient, the delta and beta genes are deleted because there's no signal coming from the delta and beta globin genes. And in the third one, see here that HPFH3, in which you can see a half peak heads coming, saying that this individual is heterozygous for HPFH3 mutation. And using this combination of gene dosage and MLPA, we screened all the cases in which we could not see the common mutations, and we finally found all the mutations, characterized them in all the heterozygous with high hemoglobin F that we had. And we found that these are the mutations in the individuals heterozygous with HbF. So we did not stop with, what I'm trying to say, we did not stop with just doing the diagnosis of beta thalassemia alone. We also we developed the methods to do the diagnosis of delta beta thalassemia and HPFH. And now we have the technique to detect all the cases of HPFH and delta beta thalassemia. So this is all about in beta thalassemia and delta beta thalassemia. I just want to go through alpha thalassemia and 3 minutes. Oh, okay, I'm really going to go fast. And alpha thalassemia is mainly caused by deletions and large deletions affecting both alpha-2 and alpha-1 globin genes have been reported. And we have, and to make sure that we do the diagnosis of almost all cases of patients with HPH disease. And it was important because we get patients with thalassemia intermediate phenotype, and we really don't think that it is because of any beta thalassemia mutations. We had to develop this multiplex PCR to detect all the alpha globin mutations. And after detecting the common deletions, we do the mutations for the point mutations. And we have identified 12 different mutations, and we have seen at least in 40 cases, we have seen mutations, point mutations in alpha-2 and alpha gene causing HbH disease. And in those cases, in which we can't see the mutations, the same gene dosage methods we used, and see whether alpha-2 or alpha-1 deleted because of any new mutations, and to identify and characterize the deletions. And we rarely, but it's not necessary to do it always, that we do an MLPA and confirm whether the patient has heterozygous deletion or not. And all this, using these methods, we could do the diagnosis of all the well-characterized cases of alpha thalassemias. And we have done a prenatal diagnosis for 1,200 cases. So all these tools really helped us to do prenatal diagnosis confidently, and we have done around 1,200 cases. I'm not just talking about we have done. What I'm saying is that how these techniques really helped, and how important to put together these techniques together to have a very good molecular diagnosis laboratory for hemoglobinopathies. And when this is going on, we're developing new methods, and we have collaborated with a company from South Korea, which has developed a new method and found that it's very really exciting technology for detecting common mutation. I just want to take you through this technique here, and we can discuss the more details of this method later. And this has a tag that binding to the mutant sequence and wild type sequence. And when there's a primer that binds to the specific sequences in the tag sequence, and when that gets extended, and this tag gets released, and that binds to its complementary sequence and another duplex DNA that is present in the tube, and that when that gets extended, the reporter and quencher distance increases, and the reporter gives fluorescence there. And the wild type, because of the sequence there is different, and it does not get into the extension, and it does not give the fluorescence signal. And it is possible to use this method now to detect single base pair nucleotide changes.
I would request you to conclude.
Okay, it's 1 minute to stop this. Okay. And this method is possible to detect 14 different mutations now. We have analyzed up to 25 samples with CGene technology, and we could see the mutations in all the samples, and the assay could be finished in 4 hours. So starting from blood sample, and the results could be obtained in 4 hours' time. And it's a direct blood sample and ready in 4.5 hours in high throughput, and we're really planning to use this method for any of our future point mutation screenings, because in 5 hours we get the technique with the results starting from the blood sample. I will not go through the last technique because of the lack of time, and I'll stop here. Thank you.
Thank you, sir, for the excellent presentation. Since we are short of time, we'll be moving on to the next presentation.
Thank you.
Thank you.
Ladies and gentlemen, it gives me immense pleasure to invite my close friend, dear friend from Cuttack, Dr. Ravindra Jena. He is very passionate about hematology, very passionate about sickle cell anemia work. The number of conferences and awareness programs he's done in Odisha is commendable. He's got numerous papers, a lot of awards, and now he'll be talking to us on sickle cell anemia, what is new in the management. Dr. Jena, please.
So thank you, Chairperson and delegates. In a few minutes, I'll be talking on sickle cell disease, what is new in the management. So these are the few points which I'll be talking on. So risk prediction, hydroxyurea, RBC transfusion, iron chelation, what is the new approved drugs? Is there any possible to have safe pregnancy and future in sickle cell disease? So these are the few points which I'll be touching. What are the new developments which have occurred in these points? So 65 years old female having 5 children went to a surgeon to have a mass in the abdomen. On the X-ray found to have a completely calcified splenomegaly, and these are the bony changes. So referred to us, and she was found to have hemoglobin homozygous, sickle cell homozygous. So being diagnosed first time at the age of 65 years old. So this is not a very rare presentation. So we see quite good number of patients coming to this category. On the other hand, it's a sickle cell family. Here is the father, and he is the eldest son, and he is the youngest son. So both are the engineering students. The elder son was very stable with a low dose of hydroxyurea at about 10 milligram per kg, no VOC or no transfusion requirement. And suddenly he had a chest pain, and he succumbed within few hours. Apprehending that the same complaint might have occurred in his younger brother, I escalated the dose of hydroxyurea even to 30 milligram per kg of the body weight. Again, the same thing happened after 6 months or 8 months, so my apprehension was right. Suddenly he had a pain, and he again succumbed. We couldn't really save him. So there are few points to explain this widespread variability of the clinical severity, but in most of the cases, so risk prediction is really unpredictable in most of the cases. So therapy which has improved the outcome of the sickle cell disease, one is prophylactic penicillin. You know, infection is the commonest cause of death in pediatric sicklers, so there has been a well-standardized procedure. You should go for the penicillin prophylaxis, and so many vaccine schedules against pneumococcus and salmonella. It has been well streamlined. And there is a hydroxyurea and the red cell support. These are two therapeutic modalities which have improved the life expectancy. The benefit of the hydroxyurea is now well established. The first study was done by Churchy in 95. He concludes, it's a landmark study which conclusively proved that hydroxyurea is beneficial so far the sickle cell disease concern. It reduces the vaso-occlusive crisis. That led to the approval of the hydroxyurea in adult sickle cell patients in 1998 by US FDA. You have so many studies both in adult and pediatric which have proved that it inhibits the vaso-occlusive crisis. Hydroxyurea also reduces the acute chest syndrome, so many studies. Again, so many studies both in adult and pediatric have shown that it reduces the need for blood transfusion, it reduces the number of the hospitalization, and these are even also, it reduces the primary stroke prevention also. These are the 4 important studies which have conclusively proved that it improves the mortality and it improves the life expectancy. So even all these plethora of studies has led to routine use of the hydroxyurea in adult secular patients, but still there was skepticism. It was not used. So for the pediatric patients, many were skeptical about the fact that it can cause some side effects. So for the growth retardation is concerned, it can cause some genome toxicity. So for the pediatric patients are concerned. Though personally, I have used in pediatric populations even much before approval, I was criticizing my colleagues because there is no alternative available. Then come another landmark study, the Baby Act study in 2012. They have really done this study in infants of say 9 months to 18 months. Here the primary endpoint was reduction of the splenomegaly and the improvement of the renal functions, which was not achieved in the study. But if you look at the secondary endpoints, so like a total events on vaso-occlusive crisis or dactylitis or acute chest events or incidents of the hospitalization, all these one secondary points were significantly reduced in the hydroxyurea group in comparison to the placebo group. In a subset analysis, when they analyzed in even asymptomatic infant patients also, which were 52, roughly 54% of the total cohort, even they found that all the secondary endpoints like dactylitis, hospitalization, and transfusion requirement are significantly reduced in the hydroxyurea group in comparison to the placebo group. That led to the approval of the hydroxyurea in pediatric patients subsequently in 2017, in last year. So after that, avascular necrosis is a very common problem which occurs with the head of the femur. It can sometimes occur in the head of the humerus also. We have proved that if you use the hydroxyurea, it also reverses this avascular necrosis, more so if it's an early stage, and its benefit gradually decreases as this complication really advances. Its benefit is minimum in advanced stage of this avascular necrosis. Again, it is a contentious issue. What is the optimal dose of hydroxyurea? We have 2 schools of thoughts. One is a maximum tolerated dose. You start with 25 milligram per kg. You can escalate to 35 milligram. The target is you have to maintain the absolute neutrophil count to around 1,500 to 3,000. But this is a practice is being done in US and these others where the aggressiveness is very high or where the haplotype is Senegal, Bantu, and etc. It needs frequent monitoring, which may not be applicable so far our patients are concerned. So this low fixed dose, either 10 to 20 milligram per kg, is a very well accepted modality in Indian patients. So we have 4 Indian studies, all are prospective. So good number of the patients, both pediatric and adult patients, and we have used the same fixed dose, so 10 milligram per kg and per day. And look at, there was a unanimity that it improves so far the vaso-occlusive requirement crisis is concerned, even the transfusion requirement, and even the incidence of the hospitalization also. So all the 4 Indian studies who have used a low 10 milligram per kg, they have unanimously proved that hydroxyurea is beneficial to all of our patients. Let's highlight our study. It's a prospective study, 128 patients. Hydroxyurea was used at a 10 milligram per kg of body weight, and there was complete disappearance of the vaso-occlusive crisis in 92% of the cases, and in 87% they didn't require any transfusion. These last 2 points are very important. If you look at the hemoglobin F rise, there was only insignificant rise of the hemoglobin F. So in the absence of the hemoglobin F rise also, still it can do wonder. And look at the last point, which is most important. The incidence of cytopenia is less than 2%. So give the 10 milligram per kg and forget, ask the patient to come after 1 or 2 months. That's the usual modality, which is very commonly accepted in our Indian population, where the frequent monitoring may be a complex or may be a problem if we are going to use this maximum tolerated dose. So hydroxyurea for all our patients should be recommended to be used as a 10 milligram per kg per day to all patients of hemoglobin SS or with sickle beta thalassemia. Resistant vaso-occlusive crisis is a clinical challenge where you have to maintain the hemoglobin S below 50%, and the hemoglobin, of course, the hemoglobin has to be maintained less than 10 gram percentage. It can be achieved by red cell apheresis, and again substituted with the normal red cells where the apheresis machine is expensive, which may not be available in most of the rural India. It can be done by the simple exchange transfusion also. Of course, you have to continue your routine management also. We have seen that, we have 4 case studies, we have seen that still if you go for simple exchange transfusion in sickle cell vaso-occlusive crisis, not responding to usual standard therapy, even this simple exchange transfusion also can be beneficial. We have used in the 4 cases, they were resistant vaso-occlusive crisis and not responding to standard therapy. We have used it with simple exchange transfusion. And look at the pain scale has been significantly reduced even after 1 to 2 transfusion also at the median of 2 days only. So even the simple exchange transfusion which can be done in any center in our country, in the rural India, it can still beneficial. So for the resistant vaso-occlusive crisis concern. So one comes the red cell transfusion. So the common, you have to be very, very careful because there are many peculiar complications following the red cell transfusion is concerned. It can cause alloimmunization, it can cause autoimmunization, it can cause acute hemolytic transfusion reaction, it can cause also delayed hemolytic transfusion reactions, which is very peculiar with sickle cell to an extent of 5 to 16%. It can cause infection also. How to prevent this? So always avoid unjustified red cell transfusion. So RBC matching, again the studies have said that if you transfuse any patients with only ABO and RHD matching, the incidence could be 5 to 16%. If you go for an extended matching, means you include all this variety of the RH, means D, C, E and small c and E and K. So this incidence can be reduced to even 4 to 7%. So as on today, ABO and extended RH matching is the standard, and K matching is the standard if you are going for transfusion in sickle cell patients. Now, iron overload and chelation is an important entity. We have a variability of iron overload in patients with sickle cell disease. There are so many haplotypes. Whatever the data that are available in Western data or in Benig or Bantu haplotypes may not be same in Indian patients. We have done a study, a prospective study for 5 years, taking about 208 sickle cell patients, and what you find that in 80% of the cases, the serum ferritin could be normal or very marginally raised. Only roughly 9.6% of the patients, the serum ferritin is more than 1,000 who may require the iron chelation. And look at my surprise in that. Even in 10% of cases also, the serum ferritin is low, and we have given iron also, and the hemoglobin has improved also. So 80% cases is either normal or marginal raise, and only 10% cases they may have a high iron load, which may require transfusion. And I think I'll skip that slide. So now iron chelation is only required in about 10% of cases in our Arab Indian haplotypes. We have compared the red cell transfusion with the serum ferritin level, and a group where it was more than 1,000, it correlates with the number of transfusion, and in other 3 groups, there was no correlation so far the number of transfusion and the serum ferritin level is concerned. There is a new approved drug in 2017. In 2017, there was a new 2 approvals. Hydroxyzide got approval in children, and of course the L-glutamine is the new drug which got approved in 2017. L-glutamine, to know the mechanism of L-glutamine, how it helps in the red cell. L-glutamine helps in producing the glutamate and glutathione and NF-DAPA. So all these 3 elements are essential. It prevents the oxidative stress and damage of the red cell. That's the mechanism. So before the US FDA approved this new molecule, there was 5 studies. So the first 3 studies were in the abstract form in the in vitro laboratory studies, and the parameters were laboratory based only. There was some beneficial, it was seen so far the red cell morphology concern. I won't go to the detail. The 4th one is the only studies which were the phase 2 study in the clinical. Here the primary endpoint was the number of the vaso-occlusive crisis at the end of the 48 weeks. It was never approved. So it is a negative study. The last one is the 4th abstract form it was published. Again, the primary endpoint was the number of vaso-occlusive crisis and all these things, and this was achieved. And this was, there was significant improvement in achieving these primary endpoints in comparison to the placebo group. So after all this study of these 4 abstract formulations which was presented in various conferences, the US FDA approved that L-glutamine in an adult sickle cell disease. There are many questions raised because there was no full paper. Here comes the full paper, say 2 months back. It's a phase 3 study, a randomized placebo-controlled study, more than 5 years, in sickle cell and sickle beta thalassemia. So 152 was the study arm and 78 was the control arm. The L-glutamine was used and it was evaluated at the end of the 48 weeks. The primary efficacy point was the vaso-occlusive crisis at the end of the 48 weeks, and these are the secondary endpoint. The last one was not achieved in the study. If you look at, so this glutamine arm, it inhibits or it improves the vaso-occlusive crisis. The time to the first vaso-occlusive crisis and the second vaso-occlusive crisis improves over in the glutamine group. And if you look at the secondary endpoints also, all the secondary endpoints, so either the vaso-occlusive crisis or number of hospitalizations and transfusions, they are all better in the L-glutamine in comparison to the placebo group. But the L-glutamine is a very expensive drug in comparison to the hydroxyurea, and there was 35% of the dropout case in the study. So the L-glutamine at present doesn't really replace the hydroxyurea. So the current status of L-glutamine, I believe it, that it can be added to hydroxyurea. If there is a suboptimal response or there is intolerance or unacceptable side effects, it cannot replace the hydroxyurea as a first-line therapy as on today. So pregnancy is a very important aspect, I always tell, because many patients in Odisha, they are unmarried, they probably, there's a myth prevailing that once you have a sickle cell, you may not have pregnancy, though that is, you find so many patients are unmarried. To prove or to disprove, the first prospective study in India we conducted to know the effect of the pregnancy in sickle cell homozygous mother. We took 60 patients in the study group, and this is the 100 in the arm group. So what we found, I'll only tell you the emphasis. In about, say, 84.4% of cases, we could have successful pregnancy in comparison to the control arm. And look at, we have a 0% of the mortality. So in not a single cases, we had any mortality. If you look at the incidence of the cesarean section, it was exactly same in comparison to both groups. So pregnancy in sickle cell disease is safe, but it is still acceptable. So future, we have so many pathogens like say dehydrations, or you have adhesive interactions of various cells, we have activation of the coagulations, we have so many inflammatory molecules which has been proved to have a pathogenesis, so there are so many studies which have been addressing each element. So gene therapy, I will skip this slide because you have heard extensively in this ASH and ISBT symposium. There are ongoing studies, it's almost completed, so whole world is looking at this success of this. Obviously, since if you look at the magnitude at the socio-financial burden of this sickle cell disease, so the control program is very, very important. You know, the government of India, NHM department has already come out with a guideline to how to control the sickle cell and thalassemia, and the Benita Srivastava is very instrumental in coming this guideline. But even before that, in Odisha state also, we have a Odisha state funded sickle cell project involving say, 10 districts to how to control the sickle cell disease. But the newer one is a tri-party agreement between the Government of India, Department of Biotechnology, CMC fellow, headed by Alok Srivastava, and Government of Odisha. It is inclusive of all hemoglobinopathy across the state. It has a very important component, which it has screening and awareness, establishing the diagnosis and prenatal diagnosis in all the district headquarters, upgradation of infrastructure, training and human resource management. Our target is to reduce the number of births with the major hemoglobinopathy by 25% in 5 years. Again, the treatment facilities to all. So the whole country is looking at, if this model is going to be successful, I think this can be practiced in other states also. So to conclude, sickle cell disease in India is mild to moderate severity. Hydroxyurea to all the patients. L-glutamine is a new approved drug, can be added if there is a suboptimal response to hydroxyurea. Iron chelation is required in 10% of cases only. And pregnancy, though it's a high risk, is successful in 84% of cases and should be conducted in an institution where all the facilities are there. And lastly, so gene therapy is a piece in the horizon, and prevention by control program should be on priority almost all the states of our country. I think before I conclude, I think this information has been given by Professor Tolai. We are having a fast hope means highlight of past EHA in Kolkata, and Professor Tolai is the organizing secretary. Its brochure is there in the delegates' kits. You can all the information. I request all of you to join to make this event very successful. So thank you very much for your attention.
Thank you very much, Dr. Jana, for an excellent talk. I mean, he is a very popular teacher. He teaches in a medical college. He gives guest lectures in all the conferences of hematology, pathology, medicine. And you can see the passion with which he works on prevention of sickle cell anemia. We have two very senior hematologists in the audience. One, my teacher, Dr. Ved Prakash Chaudhary from AIMS. He's got about 50 students in this conference, and Dr. Shashi Narayan. She was formerly the HOD Pathology, Hematology in Lady Harding. Any questions? Shoot.
Yes, sir. Yes, sir. Dr. Krishnamurthy, please. Yes, sir. Yes, sir.
Hi, Krishnamurthy, Atlanta. Dr. Jaina, that was fantastic. Congratulations. I completely agree with you on your recommendation to avoid unnecessary blood transfusions because the complications are well known. So to that end, I have two questions. In two situations where blood transfusions appear to be used in India particularly. So sickle beta thal. So in the rest of the world, people do not get blood transfusions for sickle beta thal. So I understand that helminthiasis and iron deficiency is much more prevalent. So why do you think that Indian patients get transfusions for sickle beta thal if you think it is justified? Second, you had mentioned about refractory vaso-occlusive crisis. So I would press you a little bit to say refractory in what way? Refractory in multi-organ failure, refractory in acute chest syndrome, those would be indications for transfusion. Refractory in pain would probably means better pain management, but more management of anxiety or coping rather than blood transfusion. So two-part question.
So to answer your first part, look, so far I am concerned, probably so 99% of my patients, they hardly require any transfusion. But you know, this kind of acceptance and awareness would be accepted by the most of the clinicians who are treating the sickle cell patients. But wherever they are referred to us, except bearing, say, even 2 to 3% cases where there is a splenic crisis or avascular crisis like that, or in that circumstance, you give only transient transfusion support to maintain that hemodynamic stability. Or else for Indian haplotype is concerned, you know, there are more of a vaso-occlusive phenotype than of a hemolytic phenotype. What you see in Atlanta with your Senegal and Bantu haplotype. So most of the patients don't require the need of the transfusion. This is one. And second, so the resistant vaso-occlusive crisis, so I mean that, so for standard, we find good number of patients who are hospitalized. We start with the treatment of standard protocols like adequate dehydration, maintaining water, IV fluid of 3 liters per square meter body surface, maintaining oxygen saturation more than 95%, folic acid, infections control, etc. Still, you find some patients, they do not respond to pain. Pain is still persists for even more than 48 hours, even 72 hours. That's the situation where I have used the simple exchange transfusion to reduce the hemoglobin S level, though the book says you can come down even less than 50%, even without achieving that. If you reduce the hemoglobin S by even more than 10, even 15% in our 4-case series also, it still works.
Thank you, and congratulations for your great work.
Thank you. And welcome again to your India. You always enjoy your presence.
Yeah.
Simple exchange transfusion that you do, and is it manual, is it automated, and how do you monitor when do you monitor the HbS levels pre-transfusion, post-transfusion?
Actually, in our setup, we have both. We have a red cell apheresis also, we have simple exchange transfusion means, but we purposefully do the simple, but to make it prove that it can be applicable in many parts of across the rural India or the rural area. In simple exchange transfer, you go for one phlebotomy, first you remove it and then go for a normal saline, then you substitute with a normal red cell transfusion. That's the way we have done it.
And do you monitor HbS levels pre and post transfusion?
Yes, sir. So before we do, since there was a resistant vaso crisis, we want to check it what the hemoglobin S level, and after doing simply exchange transfusion 2-3 units, we have again rechecked it also, and it was found that it is probably median level of reduction was 10 to 15% only, but still it was much above 50% only.
And sir, what are the indications that we come across patients with sickle cell hepatopathy? So have you advised exchange transfusion sickle cell
hepatopathy,
where the bilirubin is 40-50?
Yes, we do come across with
your last question, please.
We do come across with sickle hepatopathy also, but whatever we manage it, I have not done it this simple exchange transfusion in setting up sickle hepatopathy. I manage in the similar way, and usually the hemoglobin is being controlled also gradually. In the last week, the gastroenterologist did the by ERCP they did this your sphincterotomy, and they put a stent, and the hemoglobin and the jaundice really come down, but I don't know whether it's a really standard procedure or not.
Yes, sir.
Yes, sir, please.
Dr. Jaina, it was a very lucid talk. I just want to say, you said 10% of your sickler need chelation.
Yes, 9.6%.
Yeah, 90. I think we need to little calm down. If you take NTBT, these all sicklers and NTBT, they have a lot of iron overload in the liver because of anemia they absorb. And if you do MRI T2 star, I'm sure we have done few. I don't live in sickler zone, but they have a high iron overload. And even for NTBT, the TIF and other many organizations, including for sickle cell, they recommend you start chelation, maintain ferritin around 500. Below
yes, sir.
that.
To correlate also with this serum ferritin and the liver iron concentration, 5 cases also we did the liver biopsy also, and we didn't found any much high level of liver iron, but of course it could be, because I have never done it all cases. I have never corroborated so far the hepatic iron.
I think what you need to do is do the serum ferritin, do MRI T2 star. In patients who have ferritin of above 500, you will find most of them will be very highly iron overloaded, and I think that needs a point to look into.
Thank you, sir. Thank you very much. Thank you, Dr. Jana. I must thank the speakers. They have done a wonderful job. What I learned from Dr. Tufan Dolai was give oral coated tablets. What Dr. Jana mentioned was that hydroxyurea 10 milligram per kg body weight. What the third speaker on genetics mentioned was, do a prenatal diagnosis, please, for thalassemia. There are countries who have no thalassemia, Cyprus. We must start pre-marriage counseling for thalassemia. And I must admire the young audience for their active participation. I think all the three speakers need a standing ovation. Thank you so very much. And I must thank the organizers for letting us be on the stage. And it was wonderful chairing this session along with Dr. Nair, my co-chairperson. Thank you.
With this, the session comes to an end. Thank you, the speakers and the chairpersons. So now we shall break for lunch. The next session will begin at 1:15 p.m. in the same hall.
Aim for is zero bleed a reality in the management of hemophilia, management of inhibitors, changing scenario, newer therapies like extended half-life products, non-factor therapies, and the gene therapy. In India, expecting the prevalence of hemophilia 1 in 10,000, we should expect almost like 1.2 lakh of people of hemophilia, and it's estimated that 1,675 new hemophilia babies are born every year, and most of the patients are still getting cryo on the plasma for the management of hemophilia, and about 30% of the patients are affected with hepatitis B and C. At present, we have hemophilia in the world. 2017 data is 1,681 are the hemophilia A patients, and 2,400 patients are hemophilia B. Undiagnosed are 700 patients, and von Willebrand's disease are 492. Only about 16% of the patients are diagnosed to the expected of 1.2 lakh population of hemophilia patients. So in coming to the, what is the status of hemophilia in our country? After 29 states and 7 union territories and 707 districts, the state support for hemophilia is 21 states are getting the support from the government, and there are 80 hemophilia, HFI has got 80 hemophilia chapters associated with it, and there are 65 hemophilia treatment centers as of now in India. What the disability of the people in India is, this is 2000 data, 2007 data, you can see here, 85% of patients had disability. Even in the patients who are actually young patients, severe disability was seen in about 38% of the patients, and after 25 years of age, majority of the patients were disabled. There was none without any disability. So what happens in our country is more and more people are disabled because lack of treatment of hemophilia, or there is no prophylaxis. So that is how can we go forward in the management of hemophilia from so much of disability to management of cure in hemophilia patients. The long-term impacts are chronic hemarthropathy, where the patient has pain, swelling, and limits the mobility of the patients, and it may necessitate the joint replacement, and limited activity can lead to osteopenia and obesity. And risk of bloodborne infections are also there because of the majority of the patients also get the cryo and the plasma, and frequent IV injections, intravenous infusions of factor can lead to venous scarring, and they have a reduced life expectancy compared to the non-hemophilic patients. So we in India, we don't give much importance to psychosocial aspects of the hemophilia patients. They also have a lot of problems they have to go through. From the birth, the coping of the diagnosis is a very, very important thing. Balancing the protectiveness with the vigilance is one thing from birth, and early childhood, they have to identify as the different from the peers is the one, and from childhood to pre-adolescence, how to manage, how to take care of themselves is important. Adolescents, they have to kept away from the sports, and education is also major. Patients might miss the school because of the hemophilia, and during the adulthood, the work pressure, and some of the patients may not even go for the schools and college, and they may not work and depend on the family for their financial support. What is the major goals in the management of hemophilia is to prevent bleeding by prophylaxis is the only goal in the management of hemophilia, and to treat with the clotting factor concentrates. The other goal is treatment of pain or the muscle deformity or the musculoskeletal damage has to be prevented or treated for the proper management of the muscle damage or the joint damage, improvement of the target joint function, and improvement in the normal activities of the daily life. For that, what we need is a place for the treatment of hemophilia patients. There should be a center where the patients can get the comprehensive care at the hemophilia treatment center. The products are important, and the good laboratory support to identify the hemophilia and inhibitor detection, and suitable manpower is important. Nursing care is very important. For all these things, we need a sustained funding resource. For this hemophilia patient, the funding, the government has supporting us, but still it is not sustained support. And the main treatment approaches are the episodic therapy and the long-term prophylaxis. Episodic therapy is when the patient bleeds, we treat, that is called episodic therapy. This still has a lot of morbidity with this episodic therapy. Long-term prophylaxis with the factor consent has decreased the ABR and has improved the patient status. The continuous replacement of factor when the patient doesn't have a bleeding, that is called as prophylactic therapy or the regular replacement therapy. What is the status of prophylaxis in India is, you can see the majority of the patients in India are less than 18 years. 61% of the patients, in view of these things, these patients should be on prophylaxis to make them a very useful citizens and to make their life better. But in India, only less than 1% of the patients on prophylaxis. There's a huge gap in the treatment of managed hemophilia patients in our country. And what is the goal of prophylaxis? We all actually have read what is you convert a patient of severe hemophilia to a moderate hemophilia where you're expecting the factor level to rise more than 1%. This was always the principle of prophylaxis. Now, in the era of many new therapies, the threshold to maintain the factor level is increased, and the goal of maintain the factor level is higher and higher to patient not to have a bleeding. The intensity of the prophylaxis are the full dose prophylaxis where you give higher dose of factors ranging from 25 to 40 units per kg. Intermediate dose is 15 to 25 units per kg. Escalating dose is you start with a lower dose and increase to the higher level, increase the frequency of infusions, and low dose prophylaxis and individualized PK-driven prophylaxis is the best way for the personal prophylaxis in hemophilia patients. But in India and the developing countries, what we are doing is only the low-dose prophylaxis. And will see in next few slides, is it effective and do we have any Indian evidence for this? Initially, patients were only on the episodic therapy. Now we are moving towards the low-dose prophylaxis in our country. And this is the first paper where the low-dose prophylaxis has shown efficacy is that 83% reduction in the bleed rate was seen in the low-dose prophylaxis of 10 units per kg twice a week or 20 units per kg once a week in hemophilia B patients. See, significant reduction in the bleed rate was seen of 83%. And this is a long-term data. But the first one is only 3 months data of low-dose prophylaxis. And this is the long-term data of Tunisia where the patients were put on low-dose prophylaxis and the patients were followed up for 5 years. So if we put on the patients for low-dose prophylaxis, what we have to tell them after 5 years, what's happening with the joint status at the bleed rate. You can see here after 5 years, the mean bleed rate has reduced to 0.7 from 0.5 compared to 7 at the beginning. So there is a reduction in the bleeding compared to the patients on episodic therapy. So low-dose prophylaxis also works in the patients of hemophilia. So do we have any Indian experience? Yes, we have got many Indian poster presentation of the publications where you can see this is the first paper by S.P. Verma and from Pondicherry where they have shown that randomized low-dose prophylaxis effective in the management of hemophilia patients. This is the second one from the Neeraj Siddharthan and this is from our center where we have shown low-dose prophylaxis effective in the management of hemophilia patients. So what are the benefits of prophylaxis is there is 83% reduction in the joint hemorrhages and 66% in the joint function. So we are only talking about the 83%, the remaining what is happening to the remaining patients that we will talk in the next few slides. The prophylaxis produces the best orthopedic outcome and few days are lost from the work or the school and reduction in the life-threatening bleeding is also seen and there is 6-fold reduction in the joint damage and 83% reduction in the joint damage was seen. The benefits of, these are all the effects of high-dose prophylaxis. So do the patients on prophylaxis have a breakthrough bleeding? Yes, they have a breakthrough bleeding during the prophylaxis. You can see this was about 3 years they followed up and they saw even in the patients on high dose prophylaxis they had an ABR of more than 2. So patients on prophylaxis also bleed because we are not aiming for the higher level of factor to maintain in these patients. Is all patients on prophylaxis is compliant to the therapy because every other day they have to prick, actually they have to get a prick. So how many patients are compliant to the therapy with this such a prophylaxis is? You can see this is the data from US, that CDC, UDC program. The patients on prophylaxis improving every year from 35% in 2004 to 67% in 2015, but still around 40% of the patients are not compliant with the prophylaxis. There is still a lack of adherence to the treatment in these patients on continuous prophylactic therapy. What are the factors for the lack of prophylaxis or the not adherent to the prophylaxis? There are many factors like patient-related factors or treatment-related factors. In our system, the main thing is healthcare cost. Most of the patients are not affordable, are not accessible to the factor. The other most important what we see in our day-to-day practice is fear of inhibitors. And balancing the child's care with other peers or the work is important. The patients are actually fear of inhibitors takes them away from starting the prophylactic therapy. So challenges with the clotting factor concentrates is there is intravenous infusion and patients actually has to get prick every other day for the prophylaxis. The important other problem is the 30% chances of developing inhibitors is one of the things and only 60 to 70% of the patients will respond to the ITI. So how can we move away from all these things with the newer drugs? So the management of inhibitors, the past and the present, how can we improve the management of inhibitors? You can see the inhibitors are, this is factor 8 and this is the inhibitors. You can see this is the inhibitor and this is a factor 8. And even with the availability of bypassing agents, we see a morbidity with the factor in the patient with inhibitors and 30% of the patients develop inhibitors with the present available factor 8 concentrates. So what is the goal of management of inhibitor patient is we can give immune tolerance induction, episodic therapy, short-term prophylaxis and the long-term prophylaxis. And at present, what we are doing in India is we have just taken the baby steps towards the prophylaxis. We have started the prophylaxis in hemophilia patients, but the management of inhibitors is still very insufficient, clotting bypassing agents, and hardly any patient in India receives the ITI treatment. So we have to make a lot of effort in the management of inhibitors in our country. So this is the products available for the management of inhibitors, the APCC, activated prothrombin complex concentrates, and the recombinant factor 7, and both of them are intravenous injections, has to have very short half-life for 6 to 12 hours, and is 2 to 3 hour half-life, and this can be given as a prophylaxis, both of the drugs, but still the ABR is not less than 5 in both the patients on prophylaxis. So on the prophylaxis with bypassing agents, also patients are having the annual bleed rate of up to 5. So coming to the APCC, that is a FEBA which is available, up to 93% efficacy in bleeding episodes in a prospective study, and 79% of the bleeding episodes were controlled within 36 hours of first infusion. So the efficacy of the drug is good. And coming to this Novo 7, actually our recombinant factor 7, 86% efficacious in muscle bleeds, and 91% in joint bleeds, and 93% in joint and muscle bleeds, and it could control the bleeding as early as 5 years of the therapy. What are the unmet needs in the management of inhibitors is bypassing agents are given intravenous, and they do not offer consistent protection. You can see here the patients on prophylaxis with the FEBA and patients not on prophylaxis with the FEBA. You still on patient with the FEBA prophylaxis has some amount of bleeding. There is only 72% reduction in the patients on prophylactic therapy with the bypassing agents. So next, coming to the ITI is immune tolerance induction. This is a very intensive treatment. The patient has to get factor infusion every day or every alternate day. The patient has to get the central line, or they have to get the pricks every day or every second day. And it may last up to 12 months to 18 months. So patient involves a multiple rounds of treatment sometimes. The ITI actually effective only in about 60 to 70% of the patients, and ITI may also include some of the drugs called as rituximab and cyclophosphamide has to be given. And the cost of ITI in our setting is about 5.2 lakh rupees per month. The patient might require ITI for about 6 months to maybe about 6 months to 18 months, and it is only I'm talking about the low dose ITI. I'm not even talking about the high dose ITI where the cost will be very huge. Okay, what do we need to do to improve the care in hemophilia is we need to have a longer half-life products, less frequent injections, and higher trough level. And if possible, we should decrease the chance of development of inhibitors. So what are the products which are available with the longer half-life is there are 3 technologies which is available as of now is extended half-life products is chemical modification, fusion with the protein, or single chain factors. Chemical modification, what we have is the pegylated products are the glycopegylation, and fusion with the protein we have is FC fusion products with the immunoglobulin or the recombinant albumin and single chain factor 8. So these are the products which are available to cause the extension of the half-life of the factor 8 or the factor 9. So this is all the studies with the factor 9. You can see the half-life has extended up to 102 hours from 82 to 102 hours, and all these patients has received the factor weekly once or once in 2 weeks. So patients used to get factor almost twice a week or 3 times a week is getting the injection once a week. So there is definitely improvement is happening with the extension of the factor half-life, but still we are seeing the annualized bleed rate ranging from over 2 to 3 with the extension half-life product, but this still definitely made a difference with the number of infusions. This is the factor 8 where the half-life is ranging from 19 hours to this 14 to 19 hours, and the patients can get the factor every 3 to 5 days. Sometimes we can get the patients twice a week. So the ABR is ranging from again 0 to 2 with the extended half-life products. Do we have any long-term effect of these drugs? Yes, there is a long-term follow-up to 3.2 years. This is still showing an effective, and the patient do not have any inhibitors with this drug, and annualized bleed rate is 2 to 3 in the patients on long-term follow-up, and it's shown efficacious in adults and pediatric patients also. Is it possible to achieve 0 bleeds in PWH? Yes. How can we achieve the 0 bleeds? Is you can see here all these extended half-life products actually are aiming for the 0 bleeds. With the help of these extended half-life products, up to 40% of the patients had 0 bleeds on the prophylaxis. So that is how the treatment of hemophilia is progressing from prophylaxis to the now we are aiming for the 0 bleeds, and even with the factor 9 we are aiming for the higher, actually higher. Many of the patients are not having bleed during the prophylaxis. That is how a lot of improvement is happening in the management. So what is the aim of prophylaxis in the present or the future is, this is the patient critical level of factor has been defined in the management of hemophilia is less than 1% is the higher prone for bleeding. So this is actually shows the probability of not having a bleed with the amount of time they spent below the critical level. If somebody has spent a longer time, the probability of not having bleed is very less in these patients. And this is with the standard of-life products and the extended of-life products. In extension of-life product, this is a hypothetical figure. Many of the patients spend more time with less than critical level of the factor, and the patients might prone for more bleeding. So this is actually coming to the 0 bleeds. This is a paper, very famous paper of prospective randomized control studies, where the patients who had 0 bleeds also had MRI changes, and this is showing that patients, even with the 0 bleeds, can have a micro bleeds and leading to the joint damage. So now we have to aim for the higher factor level than the 0 bleeds in our day-to-day practice of these patients. What do you aim for the higher factor level is, this is a study which has shown that the patient who had got a factor level of more than 12%, actually those are the patients who had no bleeding. So what is, if at all, if you want to aim is, we should aim for about 10 to 15% of the factor we should aim for the better management of hemophilia patients. What are the practical considerations for switching from low standard half-life product to extended half-life products is, if the patient is very active, you can actually increase the trough level, continue the same frequency and increase the trough level. If the patient is less active, have a problem with the venous access, you can decrease the infusion. That is how we can manage the day-to-day practice in the extended half-life products. The definition of extended product is different compared to the standard of products. Along with all these definitions, what we consider is the pegylation and the FC fusion products are considered as the extended half-life products. So what are the challenges with extended half-life products is, again, it's an intravenous injection. We can increase about twice a week to once a week infusion, but still patient has to get the pricks. So that is what actually we face challenges with the extended half-life products. The next is the IV injection, actually. The patient has to get the IV injection almost like every other day or once a week. With the advent of newer drugs, we have got non-factor therapies. Majority of these injections are subcutaneous, where the patients can easily learn the injections, and it is acceptable compared to the IV injections in a factor replacement in hemophilia patients. Is there any other treatment apart from factor 8 and 9 concentrates useful in hemophilia patients? Yes, there are many things are happening in the management of hemophilia patients. Is you can use anti-TFPI is against the tissue factor pathway inhibitors, and you can use sRNA against the antithrombin to decrease the production of antithrombin. And the major advantages is, this is a monoclonal antibody is the factor 8 mimetic antibody, where it has 2 arms and one binds to 9A and other one 8. So these are the three things which are happening new, and the many other things are happening with the use of protein C, S pathway and APC pathway. So they're all in phase 1 and phase 2 trials, and this is actually in phase 3 trials, and some of them are approved for the management of hemophilia patients. Non-factor therapies are mainly the mimetic antibody is the emicizumab, and antithrombotic pathway what we have is anti-TFPI, and the sequence modification is sRNA antithrombin. These are the drugs which are available at present for the treatment of hemophilia patients. So this is, you can see here, initially we used to only treat the patient with the whole blood at the plasma, and then came with the cryoprecipitate, where we came to know that patients are, the cryoprecipitate is rich in factor 8, then the freeze-dried lyophilized factor 8 concentrate, then inactivated factor 8 concentrates, then the FEBA, and then we came to have the recombinant products for the management of hemophilia patients, and the Nova 7. And after, between 2010 and 15, we have a lot of extended half-life products, and what we have now is the newer therapies like monoclonal antibodies and the non-factor therapies for the management of hemophilia patients. Again, you can see here, this is the progress happening in the management of hemophilia patients, but still in India, what is actually happening is, all of the patients are not able to access at least the little bit of care. Actually, primary care is not accessible in our patients. Not everyone achieves the zero bleeds, and not everyone has an access for the comprehensive multidisciplinary care. So we only have to improve our prophylactic therapy in our patients for the management. So coming to the emicizumab trials, in emicizumab trials, what they did is initially they have put the patient on non-intervention. They only observed the patients to put on the FEBA or the Nova-7, where in all the trials, Heaven 1, 2, 3, so they observed the patients for some time on only the bypassing agents and did see what's happened with the bypassing agents. Then the patient was put on intervention. And you can see in the patients on non-intervention, only on the observation, the patients, they only saw the prophylaxis with FEBA because as a Nova-7 was not approved indication for the prophylaxis. And you can see here on the patients on prophylaxis had an ABR of 8.8 compared to the patients on episodic. Still some amount of bleeding we are seeing with the prophylactic with the APCC. This is a non-interventional study with the emicizumab in the Heaven trials. And how many patients were compliant? You can see here more than 80% compliant weeks participants this is the data from showing that patients were not compliant to get the injection, because here every other day you're giving the FEBA prophylaxis and patient has to get the intravenous injections. And there is a high unmet need for the effective management of hemophilia patients with inhibitors, and participants were adherent to the APCC prescription in about 69% of the study weeks. And so they still need to intravenous injections. That is the problem. At the end of the day is patient has to be adherent to the therapy. This is coming to the pediatric population. The patients on episodic or the prophylaxis, on episodic compared to the patient's prophylaxis, they had a decreased bleeding, but still patient had some amount of bleeding on the FEBA prophylaxis. And it's all the joints the patient had bleeding during the FEBA prophylaxis. And they also had a little bit of school absenteeism and hospitalization during this treatment, during the non-intervention period, because of the intravenous injections. So with the standard of care of prophylactic therapy, pediatric patients with inhibitors show high ABR and high infusion burden. A substantial proportion of all bleeds were untreated, and most untreated bleeds did not affect the joint or the muscles. So non-intervention study shows that we need something more for the management of inhibitor patients. So what we have is the emicizumab. Coming to this, you can see here, this is an emicizumab. In the normal people, when you have a factor 8, you can see this is a factor 8. If normal amount of factor 8 is present, it binds to the 9A along the platelet surface to the factor 10, and it activates the factor 10A, and the coagulation cascade is continued. In the absence of factor 8, this is an emicizumab molecule where one arm binds to the 9A and other arm binds to 10, and it activates the factor 10 to 10A on the platelet surface, and the coagulation cascade is continued. The advantage of emicizumab is it can be given to the patients with inhibitors. Inhibitors did not interfere with the action of this drug. And you can see here the same thing has been reproduced here. It's the 9A and the 10, and activation happens in the 10A. What are the advantages of emicizumab is the factor is potential to induce inhibitors in 30% of the patients, and it's not effective in inhibitor patients, intravenous frequent injections, and less stable protection levels, because we are seeing the more ABR even with the high dose prophylaxis ABR is about 1 to 2. And emicizumab is not, till now we have not seen any inhibitors with emicizumab. Anti-drug antibodies was not, neutralizing antibodies are not seen, and it's effective both inhibitor and non-inhibitor patients, and it is subcutaneous injection, and it's a weekly dose, and its more stable levels has been achieved. So this is the first study, which is Heaven 1 study. It's adult patients more than 12 years with the inhibitor positive was taken, and non-intervention study we already went through. The patients were on prophylactic or the episodic therapy with the bypassing agents were randomized to, patients were randomized to emicizumab prophylaxis or the no prophylaxis. You can see these patients are emicizumab prophylaxis or the no prophylaxis. The patients who are on prophylactic therapy were randomized to prophylactic therapy with emicizumab. So this is why we have got multiple arms for the comparison with the management of the hemophilia patients. The patients without prophylaxis had an annualized bleed of 23.3. Patients on prophylaxis had an annualized bleed of 2.9. There is 87% reduction in the patients. No prophylaxis with the prophylaxis, 87% reduction in the bleed rate with the emicizumab. And you can see the different types of bleed, the spontaneous bleeding, joint bleeding, and even in the joint, that's where we are concerned. The joint bleed is 89% reduction in the joint bleed on emicizumab prophylaxis. And Again, this is a very important, I can see, this is a prophylactic with the bypassing agents and the emicizumab prophylaxis. Here the patients had 15.7 annualized bleed rate and patients on emicizumab had 3.3 annualized bleed rate, again 79% reduction in the bleeding with these patients. So overall efficacy has shown that actually a total of 22 of 35 patients experienced no bleeding episode while on emicizumab. Even intra-patient comparison showed better with the emicizumab treatment. Heaven 2 is a pediatric trial, actually less than 12 years, more than 50 exposures to factor 8. And here also the weekly, initially the patient received 3 milligram per kg, then went on to 1.5 milligram per kg once a week. And see the results actually. You can see the results almost all are more than 90%. Patient with zero treated bleeds was 94%. Patient with zero all bleeds 64%. Patient with zero treated joint bleeds. Coming to the joint bleeds is about 98.2%. So most of the patients did not had a bleeding during the emicizumab treatment. This is in the pediatric patients. And even the intra-parent comparison, you can see the patient's prior epidural therapy with the bypassing agents and Heaven 2 trial. So there is even in within the patient, you can see prior to the treatment and post-treatment, there is a significant reduction in the bleeding with the emicizumab. And this is the outcome of the Heaven 2 trial. The absence of treated bleeds in 94% of the patients, absence of the bleeds in 65% of the patients, and the joint bleed was 98% of the patients. So the drug has been shown efficacious with only once a week injection. So anything can be made in hemophilia patients with non-inhibitors is, so we'll go on to this actually, the safety data of Heaven 1 and Heaven 2 trial. This is the patients, some safety data. The adverse effect most commonly was infusional site reactions. That was the only thing we had seen. But the main important things where a lot of discussion is happening is the thrombotic microangiopathy or the serious thrombosis. Like about 5 patients had this problem during the Heaven 1 trial. And we'll go into the detail of this one actually, how and what is the, how does the thrombosis or the thrombotic microangiopathy with the emicizumab. Here you can see here, 111 inhibitor patients were treated with emicizumab, 37 patients treated with NOVA7, and 20 patients treated with APCC. Out of 37 patients here, none of them developed thrombotic microangiopathy or the thrombosis in the NOVA7 arm, and patients who had APCC, that is a FIBA, they went on to divide into the patients into 2 groups, one who had got less than 100 units per kg per day, and one who had more than 100 units per kg per day. In this arm also there was no problem actually. The patients did not had any problem with this arm, and patients who received more than 100 units per kg had 8 treatment episodes, and along with 5 TMAR, the thrombosis was seen in the thrombotic microangiopathy was seen in patients on emicizumab who received more than 100 units per kg per day. So we have to be careful when you're giving a higher dose of FIBA in these patients. Usually the recommendation from emicizumab is to give 50 to 100 units per kg per day and not more than 100. That is the recommendation from the drug literature. The other side effects was the infusional side reaction, and it was able to manage without any patient withdrawing from the study. And even the quality of life was much better in the patients who received emicizumab, and the patients' decreased bleeding rate and increased quality of life was seen in both Heaven 1 and Heaven 2 trial. That is how the patient, November 16, 2017, FDA approved emicizumab for the routine prophylaxis to prevent or reduce the bleeding episodes in adult or the pediatric patients with inhibitors. This the approval got emicizumab in 2017. And the next went on to do the trials in hemophilia A patients without inhibitors. Means it's only hemophilia patient. Here Heaven 3 is more than 12 years without inhibitors. Here also the patients had 96% reduction in the bleed rate, and 56% of the patients had 0 bleeds. So this is what you can see in patients with hemophilia without inhibitors. The other major thing what they have done in Heaven 4 is the patients got monthly once injections. About you think of 12 injections in a year and hemophilia patients having a 56% 0 bleeds. This only about 12 subcutaneous injections. This is the data of Heaven 4 where the patients got once a month injections of emicizumab and the patients had 56% 0 bleeds. This is about the hemophilia A patients without inhibitors. Actually in Heaven 4 there are patients where inhibitors were also there and they had shown efficacy of once a month injections. So what are the difference between extended half-life products and emicizumab is, this is an intravenous infusion once in 4 days to factor 8, once in 2 weeks, whereas emicizumab is subcutaneous injection. It's about once a week initially, and now it was approved for once in month injection, and zero bleed is ranging from about 20 to 40%, and it is about more than 90% in pediatric patients. ABR is 1 to 3 and ABR is 1 to 2, and it's not effective in patients with inhibitors, and it's effective in patients without inhibitors. Both of them don't have a data in pups. A lot of trials are going on in the pups, and there is no evidence of neutralizing antibodies here also and here also. And there is no evidence of thrombosis, but here we have evidence of thrombosis only when the patient get a higher dose of APCC, we see thrombosis or the thrombotic microangiopathy. And with this thrombotic microangiopathy, when they stopped giving FEVR, the NOVO7, patient improved. None of the patients required plasma exchange with this drug. So on October 4, 2018, FDA approved emicizumab for the prophylaxis to prevent or reduce the bleeding in hemophilia, adult and pediatric patients with or without hemophilia. So we can use even in hemophilia patients without inhibitors. This drug has been approved from the US FDA. Do you have any other drugs for the management of hemophilia? There's a futistiran. Actually, this is an siRNA against the antithrombin, where we are actually you are interfering with the antithrombin production, where antithrombin is reduced and the thrombin production is increased, and the patient have a more stable coagulation cascade and improved coagulation with this drug. And it has also shown very good results in phase 1 and phase 2. The median ABR with the is about 1 in patients without inhibitors and 0 in patients with inhibitors. The breakthrough bleeding was managed with the bypassing agents. The 48% of us bleed free, and 67% experienced zero spontaneous bleeding in extension, phase 2 extension study. So with this, futistiran is effective in patients with hemophilia A, B, with or without inhibitors, but it needs to be confirmed in the phase 3 study, and phase 3 study is actually started recruiting the patients for this. And on September 17, the study was halted because the patient developed actually it was reported as a bleed, and then went on to do the retrospective, and the patient had a thrombosis. And that's how the trial halt was lifted for the futistiran, and the phase 3 study was started actually. The anti-TFPA also has shown very good results in the phase 1 and phase 2, where you're inhibiting the tissue factor pathway inhibitor, and you're improving the coagulation cascade. And what are the non-factor therapies are? They've got a very long half-life. They're given subcutaneously. They're useful in hemophilia A patients with or without inhibitors. And none of them have shown neutralizing antibodies till now. And dose of FEVR, factor 8 has to be given less dose in the patients on this drug. And other NFTs also have shown very good results. Even in emicizumab and other NFTs like futistiran also have shown good results. So do we have anything else compared to the non-NFTs? Yes, there is a gene therapy has shown a very promising results in the management of hemophilia patients. This is the first gene therapy has shown very good results, and it has been published in NEJM, and they have used 3 doses of vectors. Is used this AAV5 vector was used in this study, and see the results. Actually, patient had a normal factor level, 8 levels, varying from about 50 to 150. It was maintained for 1 year. So there is a hope to the cure hemophilia patients, and whether it was sustained, you can see this is the 2-year data from WFA 2018. The factor level was maintained at 59% at 2 years. So we have a sustained increase in factor 8 level with the gene therapy in factor 8 patients, and the main side effects is the elevation of the liver enzyme because the immune response, the patients respond to the steroids with this drug. Only 2 patients had a serious adverse effect, 1 required the admission because of the drug immune reaction, and other was not related to the drug. And the next is, do we have anything for the factor 9? Yes, definitely. The factor 9, we have this. This is a 3.2-year follow-up where the patient had a factor level of 1 to 6%. Anybody can tell what is the use of giving 1 to 6%, but still 90% reduction was there with this gene therapy up to 3 years. The level were maintained for 3 years. And there is a new things happening in the gene therapy in factor 9, where you are inserting the factor 9 padua. This where have got a patient has got a higher factor 8 levels, up to 40% was maintained with this new gene therapy with the SPARC drug. And what we are aiming now is, initially we used to give only factor to maintain intermittently factor 8 level, and now we have got extent of applied products, we are maintaining the higher level. With the non-factor therapies, we are maintaining much higher level of factor 8, and with gene therapy, we are curing the hemophilia patients. So there is a lot of advances are happening in the management of hemophilia patients, from factor to the extent of life products to the non-factor therapies and the gene therapy. So there is definitely a step towards actually improving the management of hemophilia patients. We all should go home with the message that prophylaxis is the standard of care in our patients. Aiming for higher trough levels, not to have a bleed, is the goal in the management. And extended off-label products are a better option because they maintain higher trough levels and safe frequency of infusion and can increase the compliance of the patients. And hemophilia patients management is improving for the last 2 decades. Non-factor therapies like amisulpride, which is the only one at present which is available, is a breakthrough in the management of these patients. With all the new drugs and success of gene therapy, at least some of the drugs may become more, the factor concentration may become more affordable in our scenario. And gene therapy will take a long time to come to our country because only they can produce for about 3,000 patients they can produce in a year. So they still have to do phase 3 trial and then to get approval, and they can only manufacture that much of products. So it takes a lot of time to come to our country. So, and high dose factors, because we are patients, the factors are so difficult to get. And other thing is to get intravenous injection. The compliance becomes difficult, and the logistic support, considering all these things. I personally feel that convention factors, high dose, and the practical aspects of nursing care, intravenous infusion, home therapy, even with the ABR of 2 to 3, imicizumab is a better option for us to start prophylaxis in our patients. The cost is not an issue. So the cost is in the affordable range. We can start the patients on this drug because it's easy, subcutaneous injection, and once a month infusion. So rather than the factor 8, we have to give about 2 to 3 times a week. This will be a better option in our scenario. So now we are moving from this. Actually, in the past, we had patients with all this deformity. Now at least we have the patients on a prophylaxis of better care we are doing. In the future, we might aim for a higher factor level where the patients can become more active in the day-to-day life. I thank you. And if there are any questions, I'm happy to answer. If there are any questions, so if there are no questions, I think I'll end this session. Roche people want to talk anything? No. Okay, we will end this session. Thank you, everyone.